Hello guys. Clear? Hello guys, happy to see you all again. Now in today's class we'll be having a rapid revision for the upcoming FMGe exam. Okay? Sound. Okay. So today we are going to have the rapid revision for the upcoming FMGe exam. I will be going in a fast phase so that we can cover the most of the topics. Okay. First itself I am telling you, if you go through this video, okay, if you go through this video, this will be sufficient for your exam. Okay, most of the questions that will be coming from this video. How many questions will be coming from the physiology? So somewhere around 10 questions. Okay, so somewhere around 10 questions will be coming from the physiology, and most of the questions that I can guarantee you that will be coming from this video or this particular rapid revision. Okay, having said that, first I will be discussing the systems. Okay, I will give you a break after 2 hours, somewhere around after 2 hours. After that again I will be going through the general topics. Okay, mainly I will be concentrating on the high yielding topics. Okay, I am going through the workbook. I will be mainly concentrating on those high yielding topics which will be asked in the exam. Okay, I am not going to go through each and every topic. Most important topics for the exam. Okay. Having said that, without any further late, let's begin our class. Okay. First, let's start with the cardiovascular physiology. In the cardiovascular physiology, even the recent exams, even the recent NEET PG exam and the FMGe exam, this question has been asked regarding the action potentials of the pacemaker cell. That's the SA node. You all know in the heart what is the pacemaker cell? SA node. So the SA node action potential have how many phases? See here. See, there is a orange color phase. Okay, there is an orange color phase. After that, there is this red color phase, and later there is this blue color phase. There are actually 3 phases in the action potential of a SA nodal cell. Now they will ask you, what are these 3 phases? The first phase, which I have shown here, which I am highlighting here from here to here. So this phase is called as a prepotential. Okay, in a SA nodal cell, first there is a prepotential. The voltage is little increasing. From where to where? MCQ. From the resting membrane potential, that is RMP. From the resting membrane potential. So SA nodal cells have a resting membrane potential of how much? Initially it is minus 60. From minus 60 it is increasing to minus 40. See, from here it is gradually increasing. Okay, let me erase and let me show it again for you. So initially it is at minus 60. Okay, because of certain events, because of certain ion channels, the resting membrane potential is going to the threshold potential of minus 40. So this phase is called as a prepotential. Later this red color phase which I have highlighted, this is called as a depolarization. Later this blue color phase is called as a repolarization. Okay, so how many phases are there? 3 phases. Let's write. First phase is called as prepotential phase. What is prepotential phase? From minus 60 millivolts to minus 40 millivolts. The voltage change from minus 60 millivolts to minus 40 millivolts is called as a prepotential phase. What are the events? What are the events that are happening? Why this voltage is increasing? That's an MCQ. So what events will happen during this prepotential phase? I'm not explaining you in detail, but you have to know for your exam. There are 3 events that will happen. That is, the potassium channels will close. Okay, there is a closure of potassium channels on the cell so that the potassium efflux, potassium exit out of the cell will decrease. Potassium channels will close. That's the first event. Later on, the sodium will come into the cell. Sodium will come into the cell. So sodium influx via funny sodium channels. Okay, via funny sodium channels. And not only that, during this prepotential phase, the third event that will happen is the calcium influx via P-type calcium channels. Okay, so these are the 3 events. The 2 MCQs which you should know is first, resting membrane potential of an SA node. The resting membrane potential of an SA nodal cell is minus 60 millivolts. Done. How many phases are there in the action potential of an SA nodal cell? 3 phases. One is prepotential, depolarization, repolarization. What is happening during a prepotential phase? During prepotential phase, the voltage is moving from minus 60 millivolts towards minus 40 millivolts, means getting positive. It's getting positive. What are the why it is changing from minus 60 to minus 40? Why it is changing? Because of 3 events. What are these 3 events? The potassium channels are closing, the sodium channels are opening, and sodium is coming into the cell via funny sodium channels or leaky sodium channels. The funny sodium channels are also called as leaky sodium channels. And the third event is calcium influx via T-type calcium channels. Okay, so done. Next phase is called as a depolarization, also called as a phase 0. Look here, this is the depolarization phase, which I am highlighting right now in front of you. So this phase, this red color phase is called as a depolarization phase. Now depolarization is due to, depolarization means the membrane is getting positive voltage. Okay, the membrane voltage is increasing, positivity. So this depolarization is due to calcium influx via L-type calcium channels. Okay, L-type calcium channels. Okay, calcium influx via L-type calcium channels. Next, the repolarization phase, which is also called as a phase 3, which I am showing here in the blue color, this color. Okay, so this phase which I am highlighting right now in the blue color, that's called as a repolarization phase, where the membrane voltage is decreasing. That repolarization is due to potassium efflux. Potassium efflux via delayed rectifier potassium channels. That is not that important, but this is the most important MCQ. Repolarization, wherever you see the word repolarization is a potassium dependent due to potassium efflux. So that's it. Okay, action potential of SA node completed. Next, let's discuss about the action potential of a ventricular myocyte. Ventricular myocyte means what? It's the ventricular muscle, the heart muscle, the proper heart muscle. Okay, now here, see how many phases are there. There is this red color phase. Okay, let me put small into so that you can understand. So this phase 1, 2, 3, 4, 5. There are 5 phases in the action potential of a ventricular myocyte. There are 5 different phases. Okay, first resting membrane potential. Now let's begin from here. This is the resting membrane potential, which is the phase 4. So the phase 4 is considered as a resting membrane potential. What is the resting membrane potential of a ventricular myocyte? Can you tell me, guys? What is the resting membrane potential of a ventricular myocyte? It's not minus 60, it is minus 90, somewhere around minus 90. Here it's very clearly given, it is minus 96. So resting membrane potential is minus 96. Now in your exams they will ask you, the resting membrane potential is due to which ions or which ion channels? Okay, which ion channels are responsible for the creation of the resting membrane potential? So the 2 important reasons for the resting membrane potential, the 2 important reasons for the development of the resting membrane potential is number 1 is potassium efflux. That is, potassium is going out, positive charges are going out from the cell, positive charges are going out of the cell. As the positivity is losing out of the cell is having a negative voltage, minus 90 millivolts. You can say simply minus 90 millivolts, that will be easy for you. So minus 90 millivolts. Okay, so this potassium efflux is contributing somewhere around 95%. 95% of the resting membrane potential is due to potassium efflux. Okay, next, the one more reason for the development of the resting membrane potential is the sodium potassium ATPases. Sodium potassium pumps or sodium potassium ATPases. Okay, so these are the 2 reasons. These are the 2 reasons for the development of the resting membrane potential. Okay, having said that, sir, in SA nodal cell, the depolarization, look, I have told you that depolarization is due to calcium influx. But in a ventricular myocyte, the depolarization, this phase, see, this phase which I am highlighting here in the green color, the depolarization, which is phase 0, it is due to sodium influx. It is due to sodium influx. Okay. Next, After that, there is something called as the initial repolarization, which is not that important, which I have highlighted here in the orange color. That's the initial repolarization. So what have happened during this initial repolarization? What is happening? See, this sodium, whatever is coming into the sodium influx, it is stopped. The sodium influx stopped. Sodium influx has stopped. Okay, has stopped. Now potassium efflux started. Okay, potassium started to go out. Potassium started to go out. That's why repolarization have started. Repolarization have started. Next, so this is a very important MCQ for your exams. Even this was a question asked in the NEET PG exam. See, there is a phase called as a plateau. So from here to here, there is a phase called as a plateau where the voltages are not fluctuating. Okay, where the voltage is not increasing or not decreasing. So there is a phase called as plateau or phase 2. Okay, phase 2 or plateau. Now, what exactly is happening during this plateau stage? See, during the stage of plateau, at the same time, potassium is going out and calcium is coming in. That both the events are happening simultaneously. On one side, positive charges are coming into the cell. On the other side, the positive charges, potassium, is also going out of the cell. At the same time, calcium is coming in, potassium is going out. So there is a balance. So that's why the voltage is not going to change. So right here, the phase 2 is called as a plateau. During this phase, there is a calcium influx balanced by potassium efflux. So both these events are happening. That's a phase 2 plateau. They will ask you, plateau is seen in the action potential of ventricular myocyte, not the SA node, not the AB node. Okay. Next, phase 3 is a late repolarization. Guys, remember one thing. It doesn't matter repolarization is early or late, initial or late. Always remember repolarization in heart is a potassium dependent, potassium efflux. See, here I have told you, initial repolarization, potassium efflux. Even in the SA node also, look, even in the SA node also, repolarization is due to potassium efflux. So everywhere repolarization, wherever you see the word repolarization, it is potassium efflux. Only potassium efflux is happening, potassium is going up. So with this, the action potentials of SA node and the ventricular myocyte, the important area where you can expect an MCQ is completed. Okay, resting membrane potential of SA node is minus 60 millivolts. Resting membrane potential of a ventricular myocyte is minus 90 millivolts. Plateau phase is seen in ventricular myocyte action potential. Repolarization is potassium dependent. Repolarization is potassium dependent, potassium efflux. During plateau stage, calcium is coming into the cell. At the same time, potassium is going out of the cell. Okay, answer. In one of the FMGe exam, this question was there. Okay, you know, in heart there are 3 layers. Okay, there are 3 different types of tissues, or you can say there are 3 different layers are there. One is endocardium, myocardium, epicardium. Okay, your heart is designed in such a way, your cardiac cells are designed in such a way that the endocardial cells are the first to undergo depolarization. Okay, usually when electrical impulse comes towards these cells, the first cells which will undergo depolarization is the endocardial cells. So learn this. Okay, so depolarization in heart, depolarization will move from endocardium towards epicardium, that is into out. Endocardial cells are first to undergo depolarization, followed by myocardium, followed by epicardial cells. The same nature design your heart in such a way that the epicardial cells, see the epicardial cells which are undergoing depolarization at the end are the first to undergo repolarization. So repolarization is out to in. Okay, so repolarization is from the epicardium towards the endocardium. Okay, so this is an MCQ which was previously asked, so that you should know this before going to the exam. Okay, done, sir. Next, some important points about the cardiac cycle. Okay, some important points about the cardiac cycle. Now, the cardiac cycle is divided into 2 phases. You know it. One is systole and diastole. Okay, systole and diastole. Now the systole is further divided into three subphases. Systole mein there are three subphases. What are they? In systole there is something called as isovolumetric contraction, rapid ejection phase, slow ejection phase. In diastole there are five subphases. What are they? One is the protodiastole, isovolumetric relaxation, rapid ventricular filling, next slow ventricular filling also called as diastasis, next atrial contraction. So these are the phases of a cardiac cycle. These are the 8 subphases of the cardiac cycle. Okay. Now important MCQs which you should know before going to the exam. Okay. First thing, atrial contraction. Let's begin with the atrial contraction. See, when the atria is contracting, okay, when the atria is contracting, how much blood will go into the ventricles? 30%. So atrial contraction contributes 30% filling of ventricles. Okay, so when the atria is contracting, it's going to contribute how much percentage filling of the ventricles? 30% filling of the ventricles actively. This is active filling. Okay, if 30% of the ventricles are filling during atrial contraction, then the remaining 70%, when the 70% of the ventricles are going to get filled, 30% is filling during the phase of atrial contraction. Then when the 70% of the ventricles are getting filled, in the phase of rapid ventricular filling. There is a phase called as a rapid ventricular filling, where 70% of ventricles fills. Okay, 70% of the ventricles fills. Now, during this rapid ventricular filling phase, the atria are not contracting. Okay, during the rapid ventricular filling, the blood from the atria just falling down into the ventricles because of the effect of gravity. Okay, just because of the effect of gravity, the blood is falling into the ventricles. It's happening passively. So this phase is a passive phase. This is passive filling. Okay. Now, what else they will ask you? Usually during these phases, you won't hear any heart sounds. But in abnormal conditions, certain abnormal conditions, you can hear heart sound. Like during the phase of atrial contraction, which heart sound is heard? Right? Very important. It is S4 heart sound. S4 heart sound, also called as the atrial gallop rhythm. Okay? Atrial gallop rhythm. The atrial gallop rhythm. The S4 heart sound is heard during which phase of the cardiac cycle? During atrial contraction. Is it heard normally? No, it's not heard normally. It is seen in certain pathological conditions. Can you tell me in which pathological conditions you can hear this S4 heart sound? This S4 heart sound, yes, of course, it is a low pitch heart sound heard in pathological conditions like long-standing hypertension. MCQ, S4 heart sound is heard in which conditions? Long-standing hypertension, aortic stenosis. Okay, so long-standing hypertension, aortic stenosis, they are going to cause S4 heart sound, especially left-sided S4 heart sound. Okay, then this rapid ventricular filling, the 70% filling of the ventricles. Okay, during this phase, can you hear any heart sound? Usually no, but in certain pathological conditions, you can hear S3 heart sound. So S3 heart sound is heard during which phase? Rapid ventricular filling. During the phase of rapid ventricular filling, let me write the full form here. It is a rapid ventricular filling phase. Okay, it's a rapid ventricular filling phase. You can hear the S3 heart sound. Normally? No, it's not heard normally. It's seen in some pathological conditions. Which pathological conditions? In wherever the condition where the ventricle is dilating. Any condition which causes the dilatation of the ventricle, that's going to cause the S3 heart sound. For example, like left ventricular failure, you know, whenever the left ventricle is failing, it's going to cause a dilation of the ventricle. The dilation of the ventricle is going to, like, you know, when the ventricles are dilated, and whenever there is rapid ventricular filling into the dilated ventricles, you will hear S3 heart sound. So S3 heart sound is seen in the left ventricular failure where there is dilation of ventricles. Or you can say dilated cardiomyopathy. S3 heart sound is heard in dilated cardiomyopathy. True. Okay. So we have completed the two important heart sounds. One is S4 heart sound and other is the S3 heart sound. Now, tell me, S4 heart sound is heard in which phase? Atrial contraction. But if they ask you, S4 heart sound is absent in which of the following condition? S4 heart sound is absent in. So, wherever the atria is not contracting, in those phases, the S4 heart sound is not going to be heard. So, that is the atrial fibrillation. In the phase of, in the condition called as atrial fibrillation, in a condition called as atrial fibrillation, atria are not contracting. There is atrial asystole. Atria is not contracting. So, you cannot hear S4 heart sound. True. S4 heart sound is not heard. Okay. Sometimes they can ask you, S3 heart sound, is it normal? Definitely not normal, it's pathological. But S3 heart sound is a normal in which people, which individuals? S3 heart sound, it is a physiological in, right? It is a physiological in children and pregnancy. So in these conditions, okay, one is the pregnancy and as the children and also in the young adults. Okay, S3 heart sound is usually heard. Okay, so S3 heart sound, S4 heart sound completed. Now, what are the two heart sounds which are left over? The two important heart sounds, S1 and S2. So, when you will hear this S1 and S2 heart sounds, so there is a phase called as isovolumetric contraction. In a phase called as isovolumetric contraction, you can hear S1 heart sound, which is absolutely normal. S1 heart sound is due to closure of, it is due to closure of mitral valve and tricuspid valve. It is due to closure of mitral valve and tricuspid valve. First, mitral valve is going to close. Later, the tricuspid valve is going to close. So, M1 T1 first heart sound. M1 T1 first heart sound is due to closure of mitral valve and tricuspid valve. Heard in which phase? Isovolumetric contraction. Next, S2 heart sound. S2 heart sound is going to be heard in which phase? The best answer is going to be protodiastole. Okay, but even some books mention isovolumetric relaxation. So best answer is protodiastole. But if you don't find a protodiastole in your in your options, you can also mark isovolumetric relaxation. So S2 heart sound is heard in protodiastole. If not, isovolumetric relaxation also true. S2 heart sound is due to closure of. It is due to closure of A2 P2. So aortic valve closure, pulmonic valve closure. The closure of aortic valve and the pulmonic valves is going to cause the S2 heart sound. The S1 heart sound, S2 heart sound, S3, S4 heart sounds completed. Out of all these heart sounds, which heart sounds are low pitch heart sounds? See, this S3 heart sound, S4 heart sound. In the entire medicine, there is 3 heart sound, S4 heart sound, and there is one more heart sound called as a tumor plop sound. Tumor plop sound. These 3 heart sounds, one is S3 heart sound, S4 heart sound, and there is a tumor plop sound which is heard in a condition called as atrial myxoma. Okay, so there is a tumorous condition called as atrial myxoma where there is a development of a tumor in the left atria. If a patient is having this atrial myxoma, you can hear this heart sound which is called as a tumor plop sound. It's a diastolic sound. So these are the 3 heart sounds which are low pitch heart sounds. Low pitch heart sounds. These are the low pitch heart sounds. S3, S4 tumor plop sound. S3, S4 tumor plop sound. These are the low pitch heart sounds. Now regarding the atrial myxoma, I want you to know one thing. Usually cardiac patients, usually heart patients, when they will have the more symptoms. Imagine I am a heart patient, I am having some kind of heart failure, okay, my heart is a weak heart. When I am going from standing position to lying down position, I will have more symptoms. That's called as orthopnea, you know it. When a patient is going from the standing position to the lying down position, more blood will go towards the heart, more preload on the heart, so the patient is going to have more symptoms, like he will develop the dyspnea, difficulty in breathing. But there is one condition, where when a patient is going from the lying down position to the standing position, he will develop the symptoms. One heart condition, that is atrial myxoma. So in atrial myxoma, the patient is going to develop platypnea. So what exactly is platypnea? Platypnea means when a patient is going from lying down position to standing position. So when a patient is going from the lying down position to standing position, he will develop symptoms. Okay, he will going to develop the symptoms, that is called the platypnea. So that's platypnea is going to be seen in which condition? Atrial myxoma. So tell me, in atrial myxoma, you will hear which heart sound? The tuber plop sound is going to be heard, and in a patient who is having atrial myxoma, the patient is going to have platypnea. What is platypnea? When the patient is going from the lying down position to the standing position, he is going to develop symptoms. Okay, so having said that, we have completed the cardiac cycle, the important phases and heart sounds. Right, now I will discuss about some important areas for the auscultation. Okay, important heart areas for the auscultation of different murmurs. Now see here, this is your right side and this is the left side. Very easy, right and left. On right side, you are only having one area. Okay, right side parasternal line, second intercostal space. This is the second intercostal space. This area is the second intercostal space. What you are going to hear there? Okay, what is that area? So that is aortic area. Okay, so that is aortic area. So where exactly is that aortic area is going to be located? You can hear certain murmurs over there. Where exactly the aortic area is located? Aortic area is the right side, second intercostal space, parasternal line. Exactly on the opposite side, that's the left side, in the second intercostal space, there is one more area. What is that? That is the pulmonic area. Okay, same, it's on the left side of the sternum, second intercostal space, parasternal line. Okay, you can hear certain murmurs over there. Down to it, in the third intercostal space, same, exactly down to it, look here, this is the third intercostal space. So this point is called as the Erb's point. Okay, this point is called as the Erb's point, where you can hear the splitting of the heart sounds, A2, P2, like you can hear the splitting of the heart sounds in this particular area called as the Erb's point. I'm not going to the details. Where exactly is Erb's point located? Erb's point is located on the left side, third intercostal space, parasternal line. That's it. Down to it, there is tricuspid area. Okay, this area which I am highlighting right here, this is the tricuspid area. Where exactly tricuspid area located? Left side, parasternal line, fourth intercostal space. Okay, the most important area for the auscultation. So that's the mitral area. See, this area is the mitral area. Where exactly is this mitral area located? Fifth intercostal space. A mid-clavicular line. Not exactly mid-clavicular line, I should say. It is 2 centimeters medial to the mid-clavicular line. Okay, but anyway. So mitral area. Where is it located? Left side. Okay, left side of the sternum. Which intercostal space? Fifth intercostal space. Where? Mid-clavicular line. Okay, so these are the heart areas for the auscultation. Is it important to know for the exam? Yes, definitely important to know for the exam. Okay, I have told you already S3, S4 heart sounds. S4 heart sound, where you are going to hear it? S4 heart sound. S4 heart sound is heard in long-standing hypertension. Okay, S4 heart sound is heard in which conditions? Long-standing hypertension, aortic stenosis. I have explained you. S3 heart sound, it is heard in which condition? Dilated cardiomyopathy, or like any condition wherever there is a dilation of the ventricles, dilated ventricles. Okay, next after that, what else you should know for your exam is, usually here we are having the carotid pulse, right? Carotid pulse. Now this carotid pulse wave, I am talking about the carotid pulse. Okay, pulse wave. The pressure here is increasing during systole. When the heart contracts, the pressure in your arteries, carotid artery I am talking about, the pressure is going to increase and it's going to decrease. Okay, so this is what I am discussing. So the pressure, this is the baseline 80. That's the baseline 80. The pressure is going to increase in your blood vessels to almost 120 during systole. You know its systolic blood pressure is 120. The blood pressure is going to increase, and during diastole the pressure is going to decrease to 80 again. So pressure is going to increase and decrease. So this is a normal pulse wave. This is a normal pulse wave. In this pulse wave, there is a small dent. Okay, there is a small notch. So this is called as a dicrotic notch. So why this dicrotic notch is happening, I am not going into the details, but when it will happen, see the dicrotic notch. This dicrotic notch occurs during which phase of the cardiac cycle? It happens when? It happens during the closure of aortic valve. When the aortic valve is closed, okay, when the aortic valve is closed, then you are going to have this dip. Okay, so here also look, the closure of the aortic valve is going to cause this dip. This is called as a dicrotic notch. It's a direct single liner question. Dicrotic notch happens during the closure of aortic valve. This is the normal pulse wave. But for your FMGe exam, they will ask you, like, the single liner kind of question sometimes. Or sometimes these words will help you to identify the underlying condition. Something like, see, I am going to discuss about the abnormal pulses. You know, first one is a normal pulse. Normal pulse, pressure increases, later decreases. Pressure increases, dicrotic notch decreases. This is something normal. Now, let's see what is the condition in which there is a dicrotic pulse. Dicrotic pulse is seen in which heart condition? Can anyone tell me? Dicrotic pulse. Dicrotic pulse, D for D, D for D. Dicrotic pulse is seen in internal medicine, dilated cardiomyopathy, DCM. So in dilated cardiomyopathy, the patient is going to have dicrotic pulse, where you are going to have two peaks like this. Two peaks. Okay. Next, bounding pulse. In which condition the patient is going to have the bounding pulse? Pulses bispherians. So bounding pulse, it is seen in aortic regurgitation. Aortic regurgitation. So if you are having a 4-line question, okay, 4-stem question, they are talking about so many things. If they use the word bounding pulse, think about aortic regurgitation. Even pulses bispherians is seen in aortic regurgitation. Okay. Next most important thing for your exam, pulses paradoxus. Pulses paradoxus. What exactly is pulses paradoxus? Pulses paradoxus means, look here, during inspiration the patient is having low pulse, and during expiration the pressure is increasing. Means there is an alteration. During inspiration the pulse is decreasing, during expiration the pulse is increasing. Okay, so there is a variability in the pressure. There is a variability in the blood pressure during inspiration and expiration. Okay, so that is called as a pulses paradoxus, more exaggerated. Okay, increase in BP, decrease in BP with the inspiration and expiration, that is a pulses paradoxus. It is seen in cardiac tamponade. Of course, it is seen in other conditions also. In a condition called as a cardiac tamponade, the patient is going to have pulses paradoxus. Next, pulses parvus et tardus. Okay, pulses parvus et tardus or pulses tardus et parvus, both are same. Also called as an anacrotic pulse. This anacrotic pulse is seen in aortic stenosis. Aortic stenosis. Next, Corrigan pulse or collapsing pulse. Corrigan's pulse, collapsing pulse, okay, or water hammer pulse, or dancing carotids. Okay, dancing carotids. All these things are going to be seen in aortic regurgitation. All are seen in aortic regurgitation. So in aortic regurgitation, there are multiple changes that are going to be seen in pulse. See, here I have written aortic regurgitation, bounding pulse is going to be seen, pulses bispherians is going to be seen, pulses, water hammer pulse, collapsing pulse, dancing carotids, Corrigan's pulse. So many things are going to be seen. All these are keywords for your exam. Okay, so my main motive of today's class is to help you to solve as many MCQs as possible. Either it's directly from physiology or pathology or internal medicine. My goal is to make you solve the MCQ. Okay, so there is something called as a pulses alternance. It is seen in left ventricular failure. Okay, terminal stage, like ventricular failure, terminal stage ventricular failure. But main important things, dilated cardiomyopathy, DCM, dilated cardiomyopathy, the patient is going to have the dicrotic pulse. Next, Corrigan pulse or collapsing pulse or water hammer pulse seen in aortic regurgitation. Pulses paradox seen in cardiac tamponade. With this, the different types of pulses are completed. Okay. Now let's come to the topic of murmurs. The important murmurs which you should know for your exam. Okay, important murmurs. See, there is a murmur which is there throughout the systole. Throughout the systole, there is a murmur. How can we say, sir? Look, you know the phase between S1 and S2, the phase between S1 heart sound and S2 heart sound, the phase between S1 and S2 heart sounds are called as a systole. Okay. So, look here. There is an abnormal sound that is heard. Okay, throughout the systole. So, this is called as a pan-systolic murmur. See, it is not seen during the diastole. It is seen throughout the systole. So, it's the pan-systolic murmur or holosystolic murmur. This pan-systolic murmur or holosystolic murmur is seen in which conditions? Which conditions? For your exam, you should know three conditions. One is mitral regurgitation, tricuspid regurgitation, and VSD, MRTR, VSD. So, mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Okay, in these three conditions, the patient is going to have pan-systolic murmurs. The murmur is going to be heard throughout the systole. Done. Next, crescendo, decrescendo murmur. Crescendo, decrescendo murmurs are going to be heard in which condition? The crescendo, decrescendo murmurs are going to be heard in aortic stenosis, hypertrophic obstructive cardiomyopathy, pulmonic stenosis. So, in these conditions, okay, in these three conditions, one is aortic stenosis, pulmonic stenosis, and hypertrophic obstructive cardiomyopathy. In these three conditions, the patient is going to have a crescendo decrescendo murmur. Crescendo decrescendo murmur means the murmur intensity, the intensity of the murmur is going to increase and decrease, increase and decrease. Of course, it's a systolic murmur, no doubt in that. The intensity of the murmur is increasing and decreasing. Okay, that's it. Next, the next important murmur which I want you to know here is this murmur which is heard during the systole and even during the diastole. So, it is heard during the systole, yes, and it is even heard during the diastole. So, what is this murmur? It's a continuous murmur. Okay, it's a continuous machinery like murmur. Then in which condition? Patent ductus arteriosus, PDA. Okay, who will develop this? Who will have this patent ductus arteriosus? Those women who have suffered with rubella during the gestation. Or the baby is having congenital rubella syndrome, you know. Congenital rubella syndrome is going to cause the cataracts in the eye. It's going to cause a heart condition that is called as the patent ductus arteriosus. Okay, to close that patent ductus arteriosus, you can give indomethacin. Okay, right. So, continuous machinery like murmur, is going to be heard in patent ductus arteriosus. Holosystolic, pan-systolic murmur is heard in three different conditions, that is MRT or VSD. Crescendo, decrescendo murmur is heard in which condition? AS, that is aortic stenosis, pulmonic stenosis, hypertrophic obstructive cardiomyopathy. Okay. Now, for your exam, I want you to know certain important named murmurs. Okay, named murmurs, important named murmurs. What are they? See, Kerry-Coombs murmur. Okay, Kerry-Coombs murmur. Have you ever heard about it? Kerry-Coombs murmur. Kerry-Coombs murmur is heard in. Okay, Kerry-Coombs murmur is heard in rheumatic fever, acute rheumatic fever, acute, no, there is nothing cute about it, acute rheumatic fever. Okay, acute rheumatic fever. Austin Flint murmur. Okay, Austin Flint murmur is going to be heard in Austin Flint murmur, aortic regurgitation. Aortic regurgitation. Gibson's murmur. See, you already know about this Gibson's murmur. This Gibson murmur is nothing but this continuous machinery like murmur. I have told you the continuous machinery like murmur that is going to be heard in patent ductus arteriosus. This continuous machinery like murmur is also having a name. That name is called as a Gibson's murmur. So, Gibson's murmur is seen in patent ductus arteriosus. Next, Graham-Steele's murmur. Graham-Steele's murmur is heard in pulmonic regurgitation. Pulmonary regurgitation. Okay, so this Carvalho sign, the Carvalho sign is seen in tricuspid regurgitation. Pulmonary regurgitation is going to cause Graham-Still murmur and tricuspid regurgitation is going to cause the Kussmaul sign, and Gallaudian phenomena is seen in aortic stenosis. Gallaudian phenomena, it's a radiation of the murmur towards the axilla. Okay, radiation of the murmur towards the axilla is called as a Gallaudian sign. Usually mitral regurgitation, say mitral regurgitation, the patient is going to have the radiation of the murmur towards the axilla. But the patient who is having the aortic stenosis, will also have the radiation of the murmur towards the axilla. That is called as the Gallaudian phenomena. So whenever you see Gallaudian phenomena, aortic stenosis, Graham-Still murmur, pulmonic regurgitation, Kussmaul sign, tricuspid regurgitation, Austin-Flint murmur, aortic regurgitation, Kerry-Coombs murmur, acute rheumatic fever, Gibson's murmur, patent ductus arteriosus. That's it. So with this, all the important name murmurs are completed. Okay, important murmurs are completed. Okay. Now, after this, next I want you to know the pressure volume loop for your exam. Okay, pressure volume loop, left ventricular pressure volume loop. In your exam, they will give you this image. Okay, they will give you simply this image, and they will ask you to identify the phase. So how to understand this, sir? How to understand this? Okay, before going to explain you about this left ventricular pressure volume loop, I want to add one more point. Regarding the murmurs. Okay, I will discuss about the left ventricular pressure volume loop, but wait. See, I have discussed about different murmurs. There is a pansystolic murmur, crescendo decrescendo murmur, continuous machinery like murmur, and I have discussed some important named murmurs in front of you. Usually this murmur intensity, okay, is going to decrease. Okay, look at this. This is a very important point. I hope you have already done this in your general classes. All the murmurs decrease in the intensity. The murmur sound decrease with certain maneuvers called as a Valsalva. When you perform Valsalva maneuver, or when you stand, just simply stand, the murmur intensity, the murmur sound decreases, except in two conditions. What are they? One is a HOCM, hypertrophic obstructive cardiomyopathy. You know, in hypertrophic obstructive cardiomyopathy, the patient is going to have crescendo decrescendo murmur. And in a patient who is having the mitral valve prolapse, okay, in a patient who is having the mitral valve prolapse, in these two conditions, in dono conditions, in these two conditions, the murmur intensity will increase upon standing and will increase upon Valsalva. Okay, so that's one important point which I want you to know. So mitral valve prolapse. Who is going to have the mitral valve prolapse? What is the reason for the mitral valve prolapse? That is the degeneration of the mitral wall, like myxomatous degeneration of the mitral wall, or it can be seen in Marfan syndrome. That's okay. But if a patient is having mitral valve prolapse, what kind of sounds you will hear? If you do the auscultation, what kinds of sound you are going to hear is mitral valve prolapse is associated with the mid systolic clicks. This is the 5-star question, I should say. Very, very important. Very, very important. Okay, mid systolic clicks are heard in mitral valve prolapse. Yes, of course, these patients are also going to have late systolic murmur. MCQ. Late systolic murmur. First, mid systolic click will be here. Mid systolic click and late systolic murmur. That's it. Okay. Next, let's come to the left ventricular pressure volume loop. Now here, let me draw the left ventricle, the pressure and volume loop. This is the left ventricular pressure volume loop. On the x-axis, I am talking about the volumes. Volume of blood in the left ventricle. How much blood is there in the left ventricle? Volume of blood. Okay. Here on the y-axis, I am talking about the pressures. Left ventricle ka pressure changes. What is the pressure change in the left ventricle? Let's begin from here. Starting. Let's begin from the here. Okay, point number A. Let's say point number A. In the beginning, how much blood is there in the left ventricle? 50 ml. 50 ml blood is there. This is called as end systolic volume. End systolic volume. How much blood is there in the beginning? 50 ml is there. That's called as the end systolic volume. Okay. Now, the left ventricle is going to get filled with the blood. Left ventricle will fill with the blood. So, how much blood will come into the left ventricle at the end of the day? How much blood is going to come into the left ventricle at the end of the day? 120 ml. Okay, 120 ml. This is called as end diastolic volume. So, this phase which I have highlighted here in the pink color from A to B, let's say A to B, this phase where the volume of blood in the left ventricle is increasing, this is called as a this, what is this? What is this? What is happening? Ventricular filling. This phase is ventricular filling. Okay, ventricular filling. Now, after this, once you have 120 ml of blood, now the left ventricle is going to contract. Okay, the left ventricle is going to contract. So what happens? The pressure in the left ventricle increases. So now once you have 120 ml of blood, what happening? Now ventricle will start to contract. Now when the ventricle is starting to contract, see, when the ventricle is starting to contract, which valves will close? See, here I am talking about the left ventricle. So here this is the point where mitral valve closes. Mitral valve closes at this point B. Now what is happening? The ventricle is contracting. So the pressure in the ventricle is increasing. The pressure in the ventricle is increasing. Till how much? Till 80. The pressure is increasing. So what is this phase which I am highlighting? Let's say the green color. So this phase which I have highlighted, this is called as isovolumetric contraction. So this green phase is indicating the isovolumetric contraction where the pressure in the left ventricle is increasing. Next, from here to here, okay, from here to here, let's say. So this phase, the pressure is still increasing. The pressure is increasing to 120 mmHg. The pressure in the left ventricle is even increasing. So what is this phase called as? This is called as a rapid ejection phase. Next phase, the pressure in the ventricle is decreasing from 120 to back to 80 again. From 120 to back to 80 again. So what is this phase? This is called as a slow ejection phase. Okay, rapid ejection phase and slow ejection phase. Now the point here is, look, once the pressure is increasing more than 80, at this point aortic valve opens. Once the pressure decreases below 80 here, aortic valve closes. Aortic valve closes. Now the pressure in the ventricle, look, the pressure in the ventricle is decreasing. What is this phase called as? Isovolumetric relaxation. So what you should know? See, here I have shown you a loop where I am discussing the left ventricle ka volume changes and left ventricle ka pressure changes, pressure increasing and decreasing. So this is the left ventricular pressure volume loop. Okay. The down phase, here I am representing the ventricular filling. Next, isovolumetric contraction, rapid ejection phase, slow ejection phase, isovolumetric relaxation. That's it. Completed. So left ventricular pressure volume loops, here all the phases are completed. Okay. So left ventricular pressure volume loop also completed. The next most anticipated area for your exam, the most important anticipated area for your exam is the jugular venous pressures. See, I am discussing so many topics in the cardiovascular physiology itself because you can expect somewhere around 3 questions. Directly, indirectly, you will be getting 3 questions from the cardiovascular physiology itself. I am not talking about medicine. So I am discussing so many, like, all the related topics, so that it will be helpful for your medicine also. Okay. I highly recommend you to watch this video before going to the exam. Okay, even if you can't watch continuously, you can take a break and you can watch it later also. You can watch it, but at the end of the day, watch this video before going to the exam. Okay. Next, let's discuss about the pressure changes in the internal jugular vein. Okay, right now I'm talking about the pressure changes in the internal jugular vein, or you can say jugular venous pulsations. Usually, when you can feel the carotid pulses, right? But here in the internal jugular vein also, you can have the pressure changes, you can have the pulsations in the internal jugular vein also. Okay. So look here, these waves which I am showing you, see, there is something called as a wave, X wave, C wave, V wave, Y wave. These are different waves. For example, let's say A wave. What is this A wave? The pressure in the internal jugular vein. The pressure in the internal jugular vein is increasing. Okay. Then what is this X? The pressure in the internal jugular vein is decreasing. Okay. What is this C wave? Small chota wave, small C wave. The pressure in the internal jugular vein is increasing, little increased. Okay. Next, what is this V wave? The pressure in the internal jugular vein is increasing, and a Y wave, the pressure in the internal jugular vein is decreasing, which means according to certain cardiac events, according to the phases of the cardiac cycle, the pressure in your internal jugular vein sometimes increases, sometimes decreases, sometimes increases, sometimes decreases. Now they will ask you A wave, which means the pressure in the internal jugular vein is increasing. It is seen during when? I'm not going to the details, simply you have to by heart at this point of time. A wave is seen during atrial contraction, A for A. So whenever your atria is contracting, okay, whenever your atria is contracting, the pressure in the internal jugular vein increases. Okay, and X wave, this X wave, you clearly see here the pressure is decreasing, X. When your atria is relaxing, that causes the X wave, X descent. Okay, next C wave, the most important thing for your exam. The most important thing for your exam is the C wave. Okay, so C for contraction. When it will be seen? During the contraction of the ventricle. Okay, look here guys, when the ventricle is contracting, especially the right ventricle, when the ventricle is contracting, that causes the bulging of the tricuspid valve, into right atria. That increases the right atrial pressure. That further increases the internal jugular vein pressure. Okay, so the point which I want you to know is, when you will have this little bump, C wave is heard during ventricular contraction due to bulging of tricuspid valve into right atria. When the ventricle is contracting, the tricuspid valve bulges into the right atria, that increases the pressure in the right atria, that further increases the pressure in the internal jugular vein. So A wave during atrial contraction, X wave during atrial relaxation, C wave during the contraction of the ventricle causing the bulging of the tricuspid valve into right atria. That's it. Okay, next V wave. Now let's discuss about the V wave. Okay, so this V wave, you very clearly can see here that the V wave, the pressure in the internal jugular vein is increasing. Okay, the pressure in the internal jugular vein is increasing. So this V wave is seen during which phase? During passive atrial filling. When the atria is filling with the venous blood, remember V for venous filling. When the atria is filling with the venous blood, the atrial pressure increases. Also the internal jugular vein pressure increases. So V wave is seen during which phase? Venous filling of atria or passive filling of atria. Okay, so passive atrial filling, done. Next, Y wave. This Y wave is heard during, seen during. Y wave, you can very clearly see that the pressure in the internal jugular vein is decreasing. The pressure is decreasing. Why the pressure is decreasing? Because, or it's seen during atrial emptying. Y for empty, EMPT, Y. Okay, so atrial emptying with the opening of tricuspid valve. So atria, see, the atria are emptying the blood into the ventricles. Atrial pressure decreases, internal jugular vein pressure also decreases. So at this point of time, even if you don't understand the concept of the internal jugular, venous pressures, I highly recommend you to, by heart this area. Jugular venous pressure changes. How many waves are there? A, C, X, V, Y. 5 waves are there. Out of which 3 are positive waves. A, C, V. They are positive waves, which means the pressure is increasing. So look carefully. ACV. Look at the ACV. A, C, and V. They are picking up. So they are positive waves. But X and Y are negative waves. X and Y descent, we say. X and Y descent. They are negative waves. Okay. JVP is important. Now, in your exam, there is a chance that they will ask you about the abnormal JVPs. See, there is a condition called as atrial fibrillation. What JVP changes are going to be seen? Which JVP changes are going to be seen in a condition called as atrial fibrillation? In atrial fibrillation, there is absent A waves. In atrial fibrillation, the A waves are going to be absent. Next, in a tricuspid stenosis, okay, pulmonic stenosis, pulmonary artery hypertension. If a patient is having any of these, then which JVP changes will be seen? There will be large A waves. Large A waves are going to be seen. Next, if a patient is having atrioventricular dissociation, AV dissociation, AV dissociation is seen in which condition? Third degree heart block, or junctional tachycardia, or ventricular tachycardia. In this condition, the patient is going to have the atrioventricular dissociation. Now, if a patient is having atrioventricular dissociation where the atria is contracting on its own, the ventricles are contracting on their own, now the patient is going to have which JVP changes? There will be Canon A waves. Canon A waves are giant A waves. Okay, these are all A wave changes. Okay, absent A waves are going to be seen in atrial fibrillation. Large A waves are going to be seen in tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension. Giant A waves or Canon A waves are going to be seen in a condition where there is atrioventricular dissociation. Done. Next, tricuspid regurgitation. If a patient is having tricuspid regurgitation, the patient is going to have 3 JVP changes. 3 JVP changes are going to be seen. What are these 3 JVP changes? Okay, one is blunted X descent, prominent Y descent, tall V waves. Okay, tall V waves. Usually we call both of this together called as a CV waves. Okay, CV waves. But anyway, if a patient is having a tricuspid regurgitation, recently asked question, it's a PYQ. The patient is having the tricuspid regurgitation, the patient is going to have the blunted X descent, prominent Y descent, and tall V waves. Okay, tall V waves. Next, constrictive pericarditis. A patient who is having constrictive pericarditis is going to have 2 JVP changes. Constrictive pericarditis, both are prominent. Prominent X, prominent Y. Okay, prominent X descent, prominent Y descent. Prominent X descent means the X wave is going to be more prominent, and prominent Y descent more prominent. Okay. Next, cardiac tamponade. A patient who is having cardiac tamponade. What you are going to see? A patient who is having cardiac tamponade, you have already seen. A patient who is having cardiac tamponade is going to have pulsus paradoxus. Pulse abnormalities. I have told you pulsus paradoxus is going to be seen in cardiac tamponade. Cardiac tamponade, pulsus paradoxus. Now here I am talking about the JVP changes. Right now I am talking about the JVP changes. In cardiac tamponade, the person is going to have prominent X but blunted Y. Prominent X, blunted Y. Okay, prominent X, blunted Y. So 2 changes. Cardiac tamponade patient is going to have 2 changes. So that's it. So if you know this JVP changes, definitely 100% I can assure you one question is going to come from JVP. Normal JVP here I have told you in the beginning, ACXVY waves are normal JVP waves which are seen during different phases. Here I have discussed about the abnormal JVPs, like in cardiac tamponade with JVP changes, constrictive pericarditis with JVP changes, tricuspid regurgitation with JVP changes. Okay, so these are the points which I want you to know. If they mention this thing like non-pulsatile elevated JVP, if they use this word non-pulsatile elevated JVP, always the jugular venous pressure is continuously high. It's non-pulsatile. Okay, the internal jugular vein is non-pulsating. It's a super high pressure. It is going to be seen in cardiac tamponade. Non-pulsatile elevated JVP is going to be seen in cardiac tamponade and superior vena cava thrombosis. Okay, done. Next, let's discuss about Kussmaul sign. So what exactly is this Kussmaul sign, sir? Kussmaul sign means normally when you do inspiration, let me tell you what is normal. Normally your JVP will decrease on inspiration. Okay, normally your jugular venous pressures are going to decrease during inspiration. If they are not decreasing, okay, if they are not decreasing or if they increase, that is called as Kussmaul sign. Explanation you can go through later. Okay, see typically JVP decreases with inspiration. If it is not decreasing, see there is a lack of decrease or increase in JVP during inspiration, this finding is called as Kussmaul sign. Kussmaul sign is going to be seen in which condition for your exam? Kussmaul sign is going to be seen with certain cardiac disorders. What are they? Kussmaul for K for K. So how I used to remember K for K? Kussmaul starting with the K. So K. So constrictive pericarditis. In a patient who is having constrictive pericarditis, usually TB patients, TB, like the patient who is having extrapulmonary TB will develop the constrictive pericarditis. If a patient is having constrictive pericarditis, in that patient you will hear, you can say this Kussmaul sign, constrictive pericarditis. And restrictive cardiomyopathy or right ventricular failure. Okay, so all these things are going to be seen with the Kussmaul sign. Okay, the Kussmaul sign is going to be seen in these conditions. Okay, which conditions? Constrictive pericarditis, restrictive cardiomyopathy, right ventricular failure. What is Kussmaul sign? Kussmaul sign means the JVP is not decreasing, the jugular venous pressure is not decreasing during inspiration. It should decrease, it have to decrease, but if it is not decreasing or if it increases, inversely if it is increasing, that is called as Kussmaul sign, seen in the 3 conditions which I have gave in front of you. Okay, next, the central venous pressures. Okay, what are the central venous pressures? Central venous pressures are nothing but the right atrial pressures. The pressure in your right atria. The pressure in your right atria is nothing but the central venous pressure. The central venous pressure is increased in which conditions? Okay, now before going to tell you anything, let's look here. Guys, this is your heart with the 4 chambers. Okay, this is the right atria, this is the left atria. What is the measurement of right atrial pressure? The right atrial pressure is nothing but the central venous pressure. Central venous pressure is going to tell you what is the pressure in right atria. What is the pressure in the left atria? Who is going to tell you the pressure in the left atria? It's a pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure is indicative of pressure in the left atria. It's indicative of the pressure in the left atria. Okay, so done. Having said that, now let's discuss about the central venous pressures. So just now I have told you central venous pressure is the pressure in right atria. Okay, it is increased in which conditions? Central venous pressure is increased in which conditions? Right, you have to by heart. One is right sided heart failure or even left heart failure. So right heart failure or left heart failure, doesn't matter, the central venous pressure increases. Okay, next, tricuspid stenosis or tricuspid regurgitation, pulmonary stenosis or pulmonary artery hypertension. Okay, pulmonary embolism. So these conditions, right heart failure, left heart failure, tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, pulmonary artery hypertension, pulmonary embolism. Next, constrictive pericarditis. Next, cardiac tamponade. So in all these conditions, okay, in all these conditions, the patient is going to have increased central venous pressures. The central venous pressures are going to be more. Then in which conditions the central venous pressure decreases? The central venous pressures are going to be less, decreasing. The CVP is decreasing. In which conditions? Seen in hemorrhagic shock. Hemorrhagic shock, which means the patient is having hemorrhage. He is losing blood. He is losing blood. So less venous return towards the heart. Less venous return towards the heart means less pressure in the heart. Okay. So central venous pressure is going to be decreased in hemorrhagic shock. True. Okay. True. Next, excessive venodilation. Okay, excessive venodilation because of using of certain drugs like nitrates. So in these conditions, the central venous pressure decreases. Central venous pressure is increasing in which conditions? Decrease in which conditions? But the most important point for your FMGe exam, which I want you to know, is right atrial pressure is measured with the central venous pressure. Left atrial pressure is measured with the pulmonary capillary wedge pressure. Okay. The next concept which I want you to know for your exam is the concept of preload and afterload. Okay, the preload and afterload. The preload is dependent on the venous return. Direct singular question. Preload is dependent on venous return. Look at here. If more venous return, see, if more venous blood comes to the heart, heart have to work more or less, you tell me. if more venous blood is coming to the heart, that blood will go to the lungs. Again, that blood will come to the heart. So there will be more load on the heart. If more venous return, more load on the heart. Heart have to work more. If more blood is coming towards the heart have to work more. This is a preload. Preload is nothing but the blood that is coming to the hearts. Okay, the venous blood that is coming towards the heart. The preload is nothing but the venous return that is coming to the heart. Right? Preload is dependent on venous return. Then what is afterload? What is afterload? See, afterload, it depends on the peripheral vascular resistance. Okay, peripheral vascular resistance. Now look here, for example, see, this is your left ventricle, right? Now what if your blood vessels, these are constricted? Okay, this blood vessel, okay, if these blood vessels, there are so many blood vessels. For understanding purpose, here I am showing one blood vessel, that's the aorta. What if the blood vessels are in constricted state? That is vascular resistance. Vessels are showing more resistance. Now tell me, heart have to work more or less? Again, heart have to work more, because now vessels are in constricted state. When the vessels are in constricted state, there will be more resistance. There will be more pressure in these blood vessels because they are constricted state. There is more pressure. So heart have to work more. That is called as the afterload. Okay. So tell me, preload is dependent on venous return. Afterload is dependent on peripheral vascular resistance. Which blood vessels are having maximum resistance? Which blood vessels will show maximum constriction or maximum resistance? The TPR is maximum with the total peripheral resistance is maximum with which blood vessel? Arterioles, because they have maximum smooth muscles. Okay, so the two direct important points I have completed. The preload on the heart. The preload is dependent on a concept called as a venous return. Preload concept is dependent on the venous return. The afterload is dependent on the total peripheral vascular resistance, which is maximum with the arterioles because they have maximum smooth muscles. Okay, so having said that, now let's discuss about the three important laws. One is the Frank-Starling's law. What is the Frank-Starling's law? Frank-Starling's law tells you the end diastolic volume is directly proportional to stroke volume. End diastolic volume is directly proportional to stroke volume, which means, for example, see, normally you keep 120 ml in the heart. Okay, 120 ml of blood in the heart. In the left ventricle, you keep 120 ml blood. Heart is going to contract, 70 will come out. Okay. Now, instead of 120, you keep 200. Heart will contract, maybe 160, 170 is coming out. Means the more you fill the heart, the more will come out of the heart. The more you keep into the heart, the more will come out of the heart. Okay, so that is called as a Frank-Starling law, which means end diastolic volume. Okay, end diastolic volume is directly proportional to stroke volume. If you increase the end diastolic volume, automatically stroke volume also increases. Okay, this end diastolic volume is nothing but the preload. Okay, preload is the amount of blood in the heart. The more you keep the blood, the more the preload, the more will come out. The more the blood you keep into the heart, the more will come out of the heart. Okay, next, what is Mary's law? What is Mary's law? Mary's law is, if you increase the BP, okay, pathologically, if you increase the BP, that's going to decrease the heart rate. Increase in BP is going to decrease the heart rate. There is something called as a baroreceptor reflex. Because of the functioning of the baroreceptor reflex, whenever the BP increases, automatically our heart rate decreases. Okay, so Mary's law also completed. Now let's discuss about the cardiac reflexes. Okay, cardiac reflexes. The three important cardiac reflexes which I want you to know. The first reflex is the Cushing reflex. So what exactly is this Cushing reflex? Cushing reflex is increase in the intracranial pressure. When the intracranial pressure is increased, okay, when we increase the intracranial pressure, automatically that's going to decrease the heart rate. Okay, in any patient, for example, let's say some patient is there, okay, he is having a tumor in his brain, or he is having some hematoma in his brain. Whenever the intracranial pressure increases, automatically check his heart rate, automatically his heart rate is going to be less. So this is called as a Cushing reflex. Increase in the intracranial pressure is going to decrease the heart rate. That is called as a Cushing reflex. Next reflex is Bainbridge reflex. Bain bridge reflex. So what is this Bain bridge reflex? Bain bridge reflex. Bain bridge reflex tells you if you increase the venous return to the heart. Okay, if you increase the venous return to the heart, means more blood is coming to the heart. That is going to cause the atrial distension. That is going to cause what? Atrial distension. Yes, more venous blood is coming to the heart. That's going to cause the atrial distension. Now what happens? You tell me, if more venous blood is coming to the heart have to work more or less? Heart have to work definitely more. So now the heart rate increases. Heart rate increases. So this is called as a Bain bridge reflex. So Bain bridge reflex is nothing but increase in the blood volume or increase in the venous return to the heart or right atrial distension is going to cause the tachycardia. It's going to cause the increase in heart rate. So that's why this Bain bridge reflex is also called as the atrial reflex. I'm not discussing in details about what are the efferents, what are the afferents. Simple. When you increase the venous return to the heart rate increases. So tell me, this Bain bridge reflex, is it a bradycardic reflex or tachycardic reflex? It's a tachycardic reflex. Tachycardic reflex. Cushing reflex, it's a bradycardic reflex. Brady means decrease heart rate. Bain bridge reflex is a tachycardic reflex. Next, the third reflex is a Bezold Jarisch reflex. So, what exactly is this Bezold Jarisch reflex? So, Bezold Jarisch reflex is nothing but if you keep certain cardiac irritants, into your blood, like serotonin, veratridine, capsaicin. Okay, if you keep these chemicals like serotonin, veratridine, capsaicin into the cardiovascular system, you have just introduced these chemicals into the vasculature, into the blood. Now immediately the scientists have observed that the heart rate will come down. So these chemicals, they are going to stimulate certain receptors, from there that information will go to the brain. Something will happen. I'm not going to the details. When you keep these chemicals like serotonin, veratridine and capsaicin, these chemicals can actually decrease your heart rate. So this is called as a Bezold Jarisch reflex. The patient is going to have, yes, bradycardia, heart rate is decreasing. The patient can also have hypotension. The patient can have apnea. All these things can be seen because in one of the recent FMGe exams, this question has been asked. All of the following are the components of the Bezold Jarisch reflex, except in Bezold Jarisch reflex, yes, the patient is going to have hypotension, bradycardia and apnea can be seen, but not the tachycardia. Tachycardia is not seen. Tachycardia is seen in Bain bridge reflex. In all the reflexes, heart rate decreases except Bain bridge. In Bain bridge reflex, the heart rate actually increases. So cardiac reflexes also completed. Okay, cardiac reflexes also completed. After that, what else I want you to know in vascular physiology? Some important points are there. I'm going to highlight only the important points, not much. See, aorta, the major blood vessel. Aorta is going to have something called as the Wind-Kessel effect. Aorta is having which effect? Wind-Kessel effect. What is this Wind-Kessel effect? Wind-Kessel effect means the blood vessels will stretch and recoil back. The blood vessels will stretch and recoil back. So this is something called as a Wind-Kessel effect. Okay, so that is maximum with the aorta. How many aortas do you have? It's one single aorta. Okay, how many capillaries do you have? Can you tell me? There are millions and millions of capillaries. They will ask you the cross section area. Usually students will think aorta is having a maximum cross sectional area. No, aorta is only one, but there are many capillaries. So combined, if you take combined cross section area, capillaries are having maximum cross sectional area. See, the capillaries at the level of capillaries, these are the capillaries, you know it. Capillaries are having maximum cross sectional area. Aorta is having least cross sectional area. Okay, so that's the point which I want you to know. So this aorta, it's having maximum. Just wait. Yeah. So capillaries are having maximum cross sectional area. Aorta is having a least cross sectional area. Least cross sectional area. Wherever the cross sectional area is least, see, wherever the cross sectional area is least, there the blood velocity is going to be more. And wherever the cross sectional area is maximum, there the velocity of blood is going to be minimum. So these are the points which I want you to know. Look, capillaries, yes, they have maximum cross-sectional area. So the blood flow through these blood vessels is going to have least velocity. So regarding aorta, the 3 important points which I want you to know, aorta have the maximum Wind-Kessel effect. Stretching, recoiling back, stretching, recoiling back. Okay, then aorta is having least cross-sectional area, capillaries are having maximum cross-sectional area. Okay, next, arterioles. Let's discuss about the arterioles. Important point about the arterioles. The arterioles are also called as the resistance blood vessels. They are called as which blood vessels? Resistance blood vessels, because they have maximum peripheral vascular resistance. I have told you they have maximum TPR because they have maximum smooth muscles. Maximum smooth muscles. You tell me, if arterioles, they are constricted, means arterioles are in constricted state. Let's say arterioles are constricted. What happened to the afterload? Afterload increases because they are constricted, maximum resistance. There is more afterload. What happens to the arterioles when they are dilated? When the arterioles are dilated, blood vessels are dilated, it is easy for the heart to pump the blood. So afterload is going to be less. Okay. Next, after this, what else I want you to know is regarding the veins. Okay, regarding the veins. See, the maximum blood in your body, the maximum blood in your body is there in which blood vessels? Veins. 55% of the blood is there in the veins. So that's why the veins are called as a capacitance blood vessels. Okay, so veins are called as capacitance blood vessels, arterioles are called as resistance blood vessels. Veins contains maximum blood volume. How much blood volume? 55% of the blood volume. Okay. Next, what else you should know is, normally there is aorta, artery, arterioles, venules, veins, capillaries, something like this. Okay. But there are certain places in your body. Okay, there are certain places in your body where an artery is going to directly fuse with a vein. Arteries are directly fusing with a vein. So they are called as arteriovenous anastomosis. This arteriovenous anastomosis are present in which areas? Arteriovenous anastomosis are present in the fingertips and earlobes. Okay, in your fingertips and earlobes, there is something called as arteriovenous anastomosis, and they are having some function. That is a thermoregulation. They helps in the maintenance of the body temperature. This AV anastomosis is having a role in thermoregulation. Okay, so just know AV anastomosis is present in fingertips, earlobes. Okay, done. Now, after that, in hemodynamics, in the topic of hemodynamics, what I want you to know. In the recent FMGe exam, the question which has been asked is, in a blood vessel, if I am talking about a blood vessel, in a blood vessel, the blood is flowing in a laminar fashion. The blood is going very swiftly, very smoothly, like this. The blood is going very smoothly. That's a laminar blood flow. You see here the water coming out of this pipe in a more turbulent fashion. There is no turbulence in our blood vessels. There is no turbulence. It is the blood is going in a very smooth way, that is called as a laminar blood flow. Okay. Now question is, when the blood is going in a laminar fashion, what is the centermost cell? Okay, what is the centermost cell? See, this is a blood vessel. This is the blood vessel. The blood is going in a laminar way. The blood is going like this swiftly. What is the centralmost cell in the column? It is the RBC. RBCs are traveling in the center. It will come in your physio as well as patho also. RBCs are going in the center of the blood vessel. Okay. Having said that, now questions which you should know is the Poiseuille-Huygens formula. Okay, Poiseuille-Huygens formula. So what is this Poiseuille-Huygens formula is going to tell you? That blood flow within the blood vessel is directly proportional to the pressure difference and radius, directly proportional to the two parameters. One is the pressure difference and the radius, but indirectly proportional to the length and viscosity. Okay, indirectly proportional to length and viscosity. Now look here guys, what if the question which was asked in 2019 FMGe exam, 2019 FMGe exam, simple the question is, if a blood vessel, look, if a blood vessel is dilated, okay, if a blood vessel is dilated, or you can say the radius of the blood vessel is doubled, what will happen to the blood flow? Usually what student will think, sir, if the blood vessel is dilated, if the radius of the blood vessel is dilated, more blood will go, 2 times more blood will go. No, not 2 times, 16 times more blood will go. Okay, 16 times more blood. So if the radius of the blood vessel, if it is doubles, if the radius of the blood vessel, if it is doubles, what happened to the blood flow? What happened to the blood flow? See, the blood flow will increase by 16 times, not 2 times, because radius to the power of 4, that is simple, 2 to the power of 4, 2 into 2 into 2 into 2. If the radius is doubled, or you can say diameter is doubled, 16 times more blood flow. 16 times more blood flow. Okay. In the same way, if the radius is tripled, if the radius of the blood vessel, if it is tripled, that is 3 to the power of 4, 3 into 3 into 3 into 3, that is 81 times more blood flow. Okay, so don't say if a radius is doubled, blood flow is going to get doubled. No, if a radius is doubled, blood flow increases by 16 times. If the radius of the blood vessel is tripled, there is 81 times more blood flow. Okay, so I want you to know this one thing. So next, what else I should teach you is regarding the, in hemodynamics, regarding the clotting cascade. Definitely you can expect one MCQ from this clotting cascade every year. Every year you can expect one MCQ from this clotting cascade. Okay, so cardiovascular physiology is completed. Cardiovascular physiology, 3 MCQs will definitely come, no doubt in that. Now from this area, the clotting cascade, one MCQ is for sure. So look at here. You know, the clotting cascade consists of 3 pathways. One is something called as the intrinsic pathway. Other is the extrinsic pathway and common pathway. Intrinsic pathway, extrinsic pathway and common pathway. How to learn this clotting cascade? How to learn this clotting cascade? Always write 10 in the center. Let's begin from here. Always write 10 in the center. Write 10 in the center. Tell me how many clotting factors are there? You know 12 clotting factors are there. 12 clotting factors. So let's begin with the 12 here. 12. Before 12, what is the number? 11. Okay, write 11. Before 11, what is the number? 10. You have already written 10 over here. So before 10, what is the number? 9. Before 9, what is the number? 8. Before 8, what is the number? 7. Okay. So 2 pathways are completed. So this pathway which I have highlighted here, this is called as intrinsic pathway. Intrinsic pathway. What is intrinsic pathway? I will explain you, don't worry. Intrinsic pathway. The pathway which I have highlighted here, the 7, that is extrinsic pathway. Okay, intrinsic pathway, extrinsic pathway. Now from 10, tell me 5 2s are how much? 5 into 2 into 1. 5 2s are how much? 5, 2 and 1. This is 1. Okay, 5 to 1. So this pathway which is there in the center, this pathway is called as common pathway. So there are 3 pathways: extrinsic pathway, intrinsic pathway, common pathway. Okay. What they will ask in your exam? First of all, what are they? This 11, 12, 8, 9. What are these, sir? These are all clotting factors. Clotting factor number 12, 11, 9, 8. Okay, 10, 7. All these are the clotting factors. No doubt in that. Now, what they will ask in your exam is, say, in intrinsic pathway, first clotting factor number 12 is activated. It is activated. Who activates it? Subendothelial collagen activates clotting factor number 12. Once 12 is activated, 12 will activate 11, 11 will activate 9, 9 will activate 8, 8 will activate 10, 10 will activate 5, 5 will activate 2, 2 will activate 1. So finally 1 is activated. What is this 1? 1 is fibrinogen that will be converted to fibrin. This fibrin is going to form the clot. That's it. Completed. Okay. So this is how the pathway is going to happen. Now extrinsic pathway. What is this extrinsic pathway? Here in extrinsic pathway, there is something called as a tissue factor which is coming from the damaged tissues. It is coming from the damaged tissue. When the tissues are damaged, whenever there is a cut, whenever the tissues are damaged, the damaged tissues are going to produce something called as tissue factor or factor number 3. It will come into the blood, it will activate the 7, clotting factor number 7. Now once 7 is activated, 7 will activate 10, 10 will activate 5, 5 will activate 2, 2 will activate 1. So there is something called as the intrinsic pathway, extrinsic pathway and common pathway. In your FMG exam, what they will ask you is, factor number 7 is involved in MCQ. Factor number 7 is involved in extrinsic pathway. Factor number 8 is involved in intrinsic pathway. Factor number 9 is involved in intrinsic pathway. Factor number 5 is involved in common pathway. Okay. Next, this intrinsic pathway, it will take some time, no? 12 will activate 11, 11 to 9, 9 to 8. It will take some time. So the time is called as partial thromboplastin time, PTT. This pathway, extrinsic pathway, it will also take certain time, that is called as a prothrombin time, PT. So PT and PTT are time for intrinsic and extrinsic pathway. So they will ask you, PT measures extrinsic pathway. Intrinsic pathway is small pathway, right? Small pathway, 7 and 3, that's it, 7 and 3. So that's why small name, PT. PT is small name. This intrinsic pathway is big pathway, 12, 11, 9, 8. Big pathway, so big name, PTT. PTT. So tell me factor number 8 deficiency is going to affect. Factor number 8 deficiency is going to affect the PTT. PTT time will be elevated. Factor number 7 deficiency is going to elevate PT time. PT time. That's it. Next, what else you should know? Is for the activation of these clotting factors, 12 should activate 11, 11 to 9, 9 to 8, 8 to 10. Activation is happening, right? For the activation, you require calcium. For the activation, which ions are required? Calcium is required. Okay. Next, out of all these clotting factors, look, okay, all these different clotting factors are there, right? For the proper functioning of these clotting factors, especially factor number 2, 7, 9, 10. Okay, see the factor number 2, 7, 9, 10. You have to do a process called as gamma carboxylation. So what do you require? Gamma carboxylation. Gamma carboxylation is going to activate factor number 2, 7, 9, 10. For that gamma carboxylation, you require which vitamin? Vitamin K. Vitamin K. Okay. Now there is a drug called as warfarin. If you give this drug warfarin, now what this warfarin is going to do? Warfarin is going to take out this vitamin K. Now once the vitamin K is not there, do you think this gamma carboxylation of factor number 2, 7, 9, 10 will occur? No. So this is how warfarin will work. So what this warfarin is doing? Warfarin inhibits the vitamin K. Once the vitamin K is inhibited, the gamma carboxylation of 2, 7, 9, 10 will not occur. Now gamma carboxylation, if it is not happening, means factor number 2, 7, 9, 10 will not function. So clotting cascade will not occur. Okay. So also remember, again I am telling you, for the activation of clotting factors, you require which ion? Calcium is required. Calcium is required. Okay, calcium is which clotting factor? It is clotting factor 4. The clotting factor number 4. The clotting factor number 4. So with this, the cardiac physiology, also the hemodynamics, the vascular physiology important points are completed. I can expect, or you can expect, like somewhere around 4 MCQs, a minimum of 4 MCQs. Okay, for sure you can expect the 4 MCQs from this one single chapter itself. As it's having more weightage, I have taken almost like somewhere around 1 hour 15 minutes for this particular topic itself, because it is highly integrated with the medicine. Okay, from now on I'm going to go through the other systems. Okay, I'm going to go through the other systems, only the important topic, only important topics. Okay, because other systems have comparatively less weightage. Okay, comparatively they have less weightage. So now I will give you a break of 5 minutes. Okay, I will give you a break of 5 minutes. After that, we will go through the systems. The other systems will be completed in the next 2 hours. Okay, all the other topics will be completed in the 2 hours. The highly integrated, highly most important area is the cardiac physiology. So that's why I took almost somewhere around 1 hour 15 minutes. The other topics will be completed in the next 2 hours. Okay, so let's have a break of 5 minutes. Okay guys, after the cardiovascular physiology, now let's discuss about the respiratory physiology. In the respiratory physiology, the highly anticipated areas, one is surfactant. Okay, surfactant. See, what is this surfactant? Who is going to produce it? When it is going to be produced? The surfactant, it is produced by cells called as type 2 pneumocytes. Okay, there are cells called as the type 2 pneumocytes which are going to produce the surfactant. Okay, now when it is produced, this surfactant, it is produced somewhere around 20 weeks of period of gestation. Produced somewhere around 20 weeks of period of gestation, surfactant is produced. Okay, now surfactant production is stimulated by surfactant production in the fetal lungs, it is stimulated by glucocorticoids, or you can say steroids. Next, the surfactant production in the fetal lungs is inhibited by, okay, mainly stimulated by glucocorticoids. If you want to know, it's also stimulated by the thyroid hormones. Okay, it's also stimulated by the thyroid hormones. But who it is inhibiting? Who is inhibiting this surfactant production in the fetal lungs? It's the insulin. Okay, that's the point which I want you to know. Next, what is the function of the surfactant? The function of the surfactant is to decrease the surface tension. It should decrease what? It should decrease the surface tension, or you can say it prevents collapsing of lungs. Okay, it decreases the surface tension. It decreases the collapse. It decreases the surface tension so that it decreases the collapsing of the lungs. Now, what if the surfactant is a deficient? Okay, what if it is a deficient? It's going to cause something called as hyaline membrane disease or respiratory distress syndrome. Okay, so surfactant produced by type 2 pneumocytes, produced somewhere around 20 weeks of period of gestation, stimulated by the steroids, inhibited by the insulin, it decreases the surface tension. Okay, next, so what exactly is surfactant? Sir, is it a protein or is it a lipid? Surfactant is a lipoprotein. It's a lipoprotein. 90% it is lipid, 10% it is protein. 10% it is protein. Now, what is a major lipid in the surfactant? What is a major lipid? The major lipid in the surfactant is called as lecithin. Minor lipid is called as sphingomyelin. Okay, so major lipid is called as lecithin, minor lipid is called as sphingomyelin. The ratio between lecithin and sphingomyelin, the ratio between the lecithin and sphingomyelin, the ratio is greater than 2. The ratio of the lecithin to sphingomyelin, if the ratio is greater than 2, it indicates fetal lung maturity. Okay, it indicates the fetal lung maturity. Okay, so these are the important points about the surfactant. Okay, now let me discuss the next important area is the mechanics of breathing. Okay, so how air is going to your lungs and how air is going to come out of your lungs. Okay, during inspiration, what is the change in the intraalveolar pressure? What is the change in the intrapleural pressure? So let me note down all the points here. Mechanics of breathing. Mechanics of breathing. Just before going to the exam, you have to know all this, like all these important values. Right now, I am talking about inspiration here. Let's say inspiration. Here, expiration. Now, first let's discuss about intraalveolar pressure. Intraalveolar pressure. Okay, intraalveolar pressure during inspiration, how much it will become? Actually, it is 0. Normally, intraalveolar pressure is 0, but during inspiration, it will become -1. minus 1. Okay. And during expiration, it becomes plus 1. Now, let's discuss about intrapleural pressure. Intrapleural pressure, how it is going to change? What's the normal intrapleural pressure? The normal intrapleural pressure is minus 2.5. It is minus 2.5 mm Hg. Normal, this is normal. But during the time of inspiration, it becomes minus 6 mm Hg. Minus 6 mm Hg. Okay. And during expiration, it will come back to minus 2.5 mm Hg. You understand? These are the important values. Again, I am repeating. Intra-alveolar pressure. How much is the intra-alveolar pressure? It is 0. Normal, it is 0. But during inspiration, it becomes minus 1. It becomes minus 1. During expiration, it becomes plus 1. Okay, it becomes plus 1. What is the normal intrapleural pressure? Intrapleural pressure is minus 2.5 mm Hg. But during inspiration, during the time of inspiration, it becomes minus 6. This is the answer, minus 6 mm Hg. And during expiration, it will come back again to minus 2.5 mm Hg. So, this is the change in the intra-alveolar pressure, intrapleural pressure during inspiration and expiration. That's it. Okay. Next, what you should know? Next, what else you should know is the concept of compliance and elastance. The concepts of compliance and elastance. So what exactly is compliance? What does it mean by compliance? Compliance means how easily you can stretch a substance. How easily you can stretch a substance. See, this Apple pencil is there. Am I able to easily stretch it? No, can't. I can't stretch it. Maybe if I use some machine or machinery power, I may stretch it. But usually to stretch it, I have to give so much pressure. It's not easily stretchable. So this is less compliant. This is less compliant. So stretchability is how easily you can stretch a substance. So stretchability. So stretchability. Okay. How easily you can stretch substance. The formula for the compliance is delta V by delta P. Delta V by delta P means how much is the volume change and how much is the pressure change for a given pressure. Okay, how much volume is changing. So that is the compliance. So this is a very important formula. Compliance is equal to delta V by delta P. Now let's talk about the elastance. Elastance means elastic recoil. Elastic recoil nature of a substance. Imagine there is a rubber band. Imagine there is a rubber band. I'm stretching it. Yes, of course it is stretching. Of course it is compliant. The moment I release one end, it is going to come back. It's going to recoil back. It's going to maintain its shape. It's coming back to its shape. It is resisting the deformation. I have tried to deform it, but it is resisting and going back to its original place. So that is called as elastance. So compliance is a stretchability, elastance is recoiling back. Both are opposite. So compliance is inversely proportional to elastance. Okay, compliance is inversely proportional to elastance. Now, in your exam, they will ask you the conditions where compliance is going to increase. In which disease compliance of the lungs increases? In which disease compliance of the lungs increases? The compliance of the lungs are going to be more in emphysema. There is a obstructive lung disease called as emphysema, where the compliance of the lung is going to be more. Next, there is a restrictive lung disease called as a pulmonary fibrosis. In pulmonary fibrosis, what happened to compliance? Compliance of the lung decreases because pulmonary fibrosis, fibrotic lungs, it is hard for you to stretch the lung. So, in a condition called as emphysema, compliance increases. In a condition called as pulmonary fibrosis, compliance decreases. Now, I am talking about the same compliance of your lungs. I am talking about the compliance of your lungs during inspiration. During inspiration, you are having lungs, right? Yes. Those lungs are more compliant, or during expiration also you are having the same lungs. expiratory lungs are more compliant or inspiratory lungs are more compliant? Most of the students will think inspiratory lungs are more compliant. Inspiratory lungs are easy to stretch. No. Remember, during inspiration, whatever the lungs you are having, the compliance is going to be less. So compliance during inspiration is going to be less. Actually, there is a reason. There is a reason for that. Okay. Compliance during inspiration is less. The lungs are less stretchable. Of course, lungs are stretching, there is no doubt, but you have to give more pressure. Okay. And compliance during expiration. Compliance during expiration is more. Okay, know this point. Okay, why? There's a big story. Right now we don't have much time for that. Okay, so compliance of the lungs during inspiration is less and the compliance of lungs during expiration is more. So let me put it in the form of a graph. If I show you it in the graph here on x-axis, on y-axis, I'm talking about volume change and let's say volume change and pressure change. That is the delta P, here delta V. You know, delta V by delta P will tell you the compliance of any substance. So this is how the compliance of the lung during inspiration. I have tried to make a graph. This is how the curve is coming. This is the compliance of the lung during inspiration. Okay, and during expiration, I have calculated the compliance of lungs. This is how the curve is going to be. Okay, this is how the curve is going to be. Means, say, during expiration, the curve is on top side. The curve is on top side. The slope is more. The slope is more, right? So expiratory lungs, during the phase of expiration, whatever the lungs you are having, they are having more compliance than during inspiration. Okay, so actually there is a difference in the compliance. You are having the same lungs, but the nature of the lungs is different during inspiration and expiration. The compliance nature is different. So there is a difference. This difference is called as hysteresis. This difference is called as what? Hysteresis. Now in your exam they will ask you, okay, this hysteresis is there in the normal lungs. True. This hysteresis is due to, why there is this difference? The compliance of the lungs is kept on changing during inspiration, during expiration. The hysteresis is changing, the compliance is changing. Why? The hysteresis, this change in compliance is due to surface tension. Okay, so due to change in surface tension. Okay, due to change. So actually, you know, during, here I have written, right, during inspiration, the lung compliance is less. The lung compliance is less. Do you know why the lung compliance is less? Because during inspiration, the surface tension in lungs is more. Surface tension in the lungs is more during inspiration. And the same surface tension during expiration is less. So first of all, surface tension is changing. Surface tension is changing. As the surface tension, which is a collapsing force, as the surface tension is kept on changing, the compliance of the lung also changes during inspiration and expiration. Okay, so the difference in the compliance, is called as hysteresis. That hysteresis is due to change in the surface tension during inspiration and expiration. During inspiration, the surface tension is more, so less compliance. During expiration, the surface tension is less, so more compliant. Okay, so they will ask you about the concept of compliance and elastance. So this is what, and the most important thing is the formula. The formula for the compliance is delta V by delta P. Compliance and elastance are opposite. Okay, compliance and elastance are opposite. So can I say something like this? You tell me, compliance is also inversely proportional to surface tension. True. Both are opposite. If surface tension is increasing means what happened to compliance? Decreases. So this is also true. Okay. Now after this, what else you should know in the respiratory physiology, the high yielding topic before going to the exam is the spirometry. In the recent FMGe exam, they have asked about the spirometry. So write spirometry. The spirometry. Okay. Let's plot a graph. Something like this. Okay. Now let's have this dotted line. Okay, no need to have that. Anyway, now here x-axis, let's say y-axis. Now on y-axis, I am talking about volumes. Okay, just volume, up and down volume. Normally, look at me. I am taking air in, I am taking the air out. Okay. So during quiet breathing, air is going in, air is coming out. Right. So this air that goes into our lungs and comes out of the lungs. So how much is this? 500 ml. So this is called as a tidal volume. Tidal volume. So how much is this tidal volume? That is a 500 ml. So 500 ml is the tidal volume. That's the air goes into the lungs, comes out of the lungs. So this is the tidal volume, 500 ml. But if I ask you, you can take some extra air into your lungs. See, you have, for example, say you ask me, so take extra air. Yes, I can take. See, first normal 500 ml is going in. So 500 ml goes in. But if you ask me, I can take some extra air into my lungs. Okay. So this extra air that I have taken in, so this extra air beyond normal, beyond 500, this is called as inspiratory reserve volume. So inspiratory reserve volume. How much is this inspiratory reserve volume? I can take 3000 ml air extra into my lungs. Okay. Again, I can take it out. Again, tidal volume. Okay. If you ask me, I can take some extra air out of my lungs. Okay. After normal quiet expiration, if you ask me, I can take some extra air out of my lungs. So this extra air that I am taking out, this is called as expiratory reserve volume. How much air I can take out? Somewhere around 1200 ml I can take out. Okay. Whatever I do or how much ever I try, some air will always stay in the lungs, it will never come out. Some air is always staying in the lungs, it will never come out. It's never going to come out. Okay. So this is called as residual volume. How much is that? Somewhere around 1300 ml. So whatever you do, some air is always residual inside your lungs. That is called the residual volume, 1300 ml. So how many volumes I have discussed with you? So far I have discussed one tidal volume, 500 ml, inspiratory reserve volume, 3000 ml. Next expiratory reserve volume, this one expiratory reserve volume, 1200 ml, and residual volume, whatever you do, 1300 ml will never come out of your lungs. Okay. Now 4 volumes are completed. After these 4 volumes, now let's add these volumes. If you add these volumes, you will get capacities. So addition of volumes will give you capacities. Now, for example, let's add the tidal volume, this one, the tidal volume plus the inspiratory reserve volume. If you add this whole area, this area which I have marked here, from here to here, okay, this area which I have marked, that is tidal volume plus inspiratory reserve volume. What is this? Now this capacity is called as inspiratory capacity. So write inspiratory capacity is equal to tidal volume plus inspiratory reserve volume. That is 500 plus 3000. 500 plus 3000 how much? 3500 ml. That is my inspiratory capacity. Inspiratory capacity complete. Next, let's add these 2 volumes, residual volume and expiratory reserve volume. Okay, let's add these two volumes now. So from here to here, let's say from here to here, right? So it is including both expiratory reserve volume and residual volume. So this is called as functional residual capacity. Functional residual capacity means what? It includes residual volume plus expiratory reserve volume. If you add, it will be somewhere around 2500 ml, because residual volume 1300 ml, expiratory reserve volume 1200 ml. Okay, now let's add these three volumes which I am highlighting in the pink from here to here, starting from here till here. Okay, so it is including inspiratory reserve volume, next tidal volume and expiratory reserve volume, because this is the till here it is expiratory reserve volume. If you add these three volumes, that is the inspiratory reserve volume, expiratory reserve volume and tidal volume, okay, so it is your vital capacity. So vital capacity includes the inspiratory reserve volume plus tidal volume plus expiratory reserve volume. If you add all these three, it is going to be somewhere around 4700. If you add all the volumes starting from the tidal volume, inspiratory reserve volume, expiratory reserve volume and residual volume, if you add all the four volumes, that's going to give you total lung capacity. So total lung capacity, all four volumes, it is going to be somewhere around 6 liters. The total lung capacity is going to be 6 liters. So this is what they will ask in the spirometry. Okay, they will highlight and they will ask you. For example, let me show you what was asked in the last exam. Here, this is what is given. Now you tell me, what is this marked area from here to here? The marked area is from here to here. Tell me, what is it including? It is including expiratory reserve volume and also it is including this residual volume which will never come out. So the addition of this both expiratory reserve volume and residual volume, it is your functional residual capacity. Now if they ask you from here till here, if they mark an arrow and if they are showing from here to here, it includes inspiratory reserve volume, tidal volume and expiratory reserve volume. It is your functional residual capacity. So such questions will ask in your exam. Now some single errors. Look at the single errors. Which volumes cannot be measured with spirometry? We are normal spirometry study. Which volumes cannot be measured? So residual volume and which capacities? Total lung capacity, functional residual capacity, it can't be measured. These three can't be measured with spirometry. Okay, they can't be measured with the spirometry. Okay, next, then with which study you can measure them? Okay, with which study you can measure them? There is something called as body plethysmography. Okay, body plethysmography, nitrogen washout, helium dilution method, so these are the methods by which you can measure this residual volume, total lung capacity or functional residual capacity. Okay, so spirometry is the most important area which you should know for your exam. I have told you surfactant is the most important area, mechanics of breathing. Next, spirometry. After this, they will ask you about the ventilation perfusion ratios in a lung. Okay, ventilation perfusion ratios. ventilation perfusion ratios. In a normal lung, ventilation perfusion ratio means V by Q, ventilation by perfusion ratio. In a normal lung, the ventilation perfusion ratio is 0.8. You have to by heart this. In a normal lung, ventilation perfusion ratio is how much? 0.8. But it is little different in different lobes of the lung. If they ask you specifically about the apex of the lung, what is the ventilation perfusion ratio? In the base of the lung, what is the ventilation perfusion ratio? In the apex of the lung, ventilation perfusion ratio is 3.2. In the base, it is 0.6. This is normal ventilation perfusion ratio. In the apex of lung, it is 3.2. In the base of the lung, ventilation to the perfusion ratio is 0.6. There are certain conditions where the ventilation perfusion ratio, that is the V by Q ratio, is infinity. In which conditions the ventilation perfusion ratio will become infinity? V by Q ratio will become infinity. Seen in first, pulmonary embolism. In a condition called as a pulmonary embolism, okay, in condition called as a pulmonary embolism, the ventilation perfusion ratio will become infinity. Or anatomical dead space. Okay, in anatomical dead space also. In anatomical dead space, that is a conducting zone. In your anatomical dead space also, ventilation perfusion ratio is going to be infinity. Okay. In which condition the ventilation perfusion ratio is going to be 0? It will become 0 in some conditions. In some conditions, abnormal conditions. What are they? One is foreign body obstruction in your respiratory tract. Foreign body obstruction or respiratory tract compression or atelectasis. In these conditions, okay, in these conditions, ventilation perfusion ratio is going to be 0. So normal ventilation perfusion ratio in the apex of the lung it's 3.2, in the base of the lung it's 0.6. The ventilation perfusion ratio is going to be infinite in the pulmonary embolism, and ventilation perfusion ratio is going to be 0 in 3 conditions, that's the foreign body obstruction, respiratory tract compression or atelectasis. Okay, so ventilation perfusion ratios also important for your exam. Next, after this, next most important area is the right shift and left shift of oxygen-hemoglobin dissociation curve. Okay, so right shift and left shift of oxygen-hemoglobin dissociation curve. Okay, see, in your exam they will ask you, for example, let me show you. This is the normal curve, oxygen-hemoglobin dissociation curve. This is how it is going to be. It's a sigmoid shape. Not much details. It's a sigmoid shape. Okay. There are certain conditions in which the curve is going to have right shift, and there are certain conditions in which, okay, there are certain conditions in which the curve is going to have right shift, and in certain conditions the curve is going to have left shift. So there is a right shift. Let me show you in the pink color. This side it is a right shift, and here this is left shift, right and left shift. What does it mean by a right shift? In which conditions there is right shift, and what does it mean by right shift? Right shift means now hemoglobin is giving more oxygen to the tissues. Hemoglobin is releasing more oxygen to the tissues. Okay, so right shift indicates, right shift indicates more oxygen delivery to tissues. Okay, more oxygen delivery to tissues. Left shift, what does left shift indicates? Left shift indicates less oxygen delivery to tissues. Less oxygen delivery to tissues. Now question what they will ask you in your exam is, sir, when you will see this right shift and when you will see the left shift? Right shift is going to be seen in exercising conditions. Right shift is seen in exercising conditions. Whenever you do exercise, what happened to your PCO2 levels? The PCO2 levels decreases, partial pressure of carbon dioxide levels increases, or not decreases, increases. What happened to the partial pressure of oxygen levels? Decreases. What happened to the lactic acid production? Lactic acidosis. Whenever there is acidosis, what happened to the pH? pH decreases. What happened to the H plus ion concentration? Increases. What happened to the body temperature? Increases. So increase in the body temperature, increase in the proton concentration, decrease in the pH, acidosis, hypercapnia or hypoxia, or whenever there is this exercising conditions, there is a production of 2,3-bisphosphoglycerate or 2,3-DPG, diphosphoglycerate. The production of this chemical all going to influence the hemoglobin in such a way. Now hemoglobin will give more oxygen to the tissues. That is called as a right shift. So right shift is seen in which conditions? Exercising conditions, hypercapnia, hypoxia, acidosis, low pH, high body temperature, high proton concentration, presence of 2,3-bisphosphoglycerate. All they are going to cause right shift in the oxygen hemoglobin association dissociation curve. In which conditions you are going to see the left shift? The left shift is going to be seen in alkalosis. Exact opposite, alkalosis conditions. Whenever the partial pressure of carbon dioxide levels decreases. Okay, whenever the pH increases, proton concentration decreases, body temperature decreases, or fetal hemoglobin. Fetal hemoglobin have which nature? Left shift. So in these conditions, whenever there is alkalosis or hypocapnia, like less carbon dioxide, more pH, there is alkalosis, less protons, less body temperature, they are all going to influence the hemoglobin in such a way. Now hemoglobin is going to deliver less oxygen to the tissues. Okay, so there is going to be right shift and left shift and associated conditions. Pakka MCQ in your exam. Okay, so again in respiratory I have discussed which important topics. I have discussed surfactant, important area. Next I have discussed about the mechanics of breathing, how the intraalveolar pressure, intrapleural pressure changes. I have discussed about the spirometry. I have discussed about the ventilation perfusion ratios in normal lung and in different conditions. Also I have discussed about the oxygen hemoglobin association dissociation curve. Okay, so these are the important areas which you should know in respiratory physiology. After this, let's see the important topics that you should know in renal physiology. Okay, in renal physiology, what are the important areas which you should know? They will ask you to calculate the GFR, glomerular filtration rate, GFR, or to calculate the clearance of any substance, clearance formula. Clearance, GFR or clearance is having the same formula, that is UV by P. UV by P, this is the formula. U stands for here urinary concentration of a particular substance. Urinary concentration, how much is the urinary concentration of a particular substance? How much is the volume of urine that is getting produced? How much is the plasma concentration of a same substance, substance X? Okay, urinary concentration of a substance X or plasma concentration of the substance X. So UV by P is the formula to calculate the GFR or clearance. Important formula in the renal physiology. Okay, so what is the normal GFR? The normal GFR is somewhere around 120 ml per minute. 120 ml per minute. Okay, how to calculate this GFR formula? You know, what is the substance that is used? What is this X substance? What is the substance that is used to calculate the GFR? That is inulin. The best, inulin. You can also use creatinine. Okay, inulin is best or gold standard. Creatinine, it is widely used. It's not best, but it's widely used because it is cheap and non-toxic. It is widely available. But the problem with creatinine is it overestimates. What is the problem? It overestimates. GFR. It overestimates the GFR. Okay. So tell me GFR formula UV by P. Clearance formula also same UV by P. What is the normal GFR? 120 ml. 120 ml. What is the substance that is used to calculate the GFR? Inulin or creatinine. What is the substance that is used to calculate the renal plasma flow? How much plasma is coming to both the kidneys? Renal plasma flow. Okay, renal plasma flow. The renal plasma flow is calculated by using a substance called as para amino hippuric acid. Okay, so para amino hippuric acid is used to calculate the renal plasma flow. Now, changes in the GFR. Changes in GFR. See, your GFR need to be constantly maintained. Your GFR need to be constantly maintained. Okay, it should be always somewhere around in a normal range, 120 ml. It should be normally maintained. Okay, so there is something called as auto regulation of a GFR. Okay, there is something called as auto regulation. So who is going to regulate your GFR? Means your GFR, whenever it is increasing, it should be brought back to normal, or whenever it is decreasing, it should be brought back to normal. So there is some auto regulation. So who is going to regulate this GFR? That is macula densa. So direct question that will come in your exam, auto regulation of the GFR. Auto regulation of the GFR is done with the help of macula densa. Macula densa is sensitive to which ions? Macula densa is sensitive to sodium chloride levels in the urine. By looking at the amount of sodium chloride in the urine, it estimates how much is the GFR and it will try to maintain the GFR. Okay, so macula densa is sensitive to which ion? Sodium chloride. Where is this macula densa present? Sir, macula densa is present on thick part of ascending limb of loop of Henle. On the thick part of ascending limb of loop of Henle, there is this macula densa. Macula densa is helping in the auto regulation of GFR. If you don't find macula densa, they will also use macula densa is a part of JG apparatus. So JG apparatus. Same function. JG apparatus, it consists of macula densa, like JG cells, other cells. So auto regulation of the GFR is done with the help of JG apparatus or macula densa. Where is macula densa present? It is present on the thick part of ascending limb of loop of Henle. Macula densa is sensitive to which ion? Sodium chloride. The same macula densa, one more MCQ. It gives, yes, of course it is doing tubuloglomerular, it is doing auto regulation. How? There is something called the mechanism called as a tubuloglomerular feedback. So with the help of this tubuloglomerular feedback, see macula densa, with the help of this tubuloglomerular feedback, it is helping in the auto regulation of the GFR. Auto regulation of the GFR. Right? Done. Next, what else you should know? You know there is something called as afferent arteriole and efferent arteriole. Afferent arteriole, glomerulus, efferent arteriole, you know it? Now, let's say afferent arteriole is dilated. Afferent arteriole is dilated. What happened to the GFR? Afferent arteriole is constricted. What happened to the GFR? What do you think? If afferent arteriole, the one which brings the blood to the nephron, if the afferent arteriole is, if it is dilated, more blood will come. So more will be the filtration. So if afferent arteriole, if it is dilated, GFR increases. If afferent arteriole, if it is constricted, GFR decreases. Okay. Next, efferent arteriole. Efferent arteriole dilated. and efferent arteriole constricted. Okay, efferent. See here, this is something important. If efferent arteriole, if it is constricted, initially GFR increases, but later GFR decreases. This is later. This is initial. Okay, initially GFR increases, later decreases. This is called as biphasic response. Okay, this is what is called. This is called as a biphasic response. So efferent arteriole, if it is constricted, it is going to increase the GFR and decreases the GFR. So this is called as a biphasic response. In with efferent arteriole constriction. Efferent arteriole, if it is a dilated, efferent arteriolar dilation is going to decrease the GFR. Okay, so afferent arteriolar constriction dilation, efferent arteriolar constriction dilation, how they are going to change the GFR. Okay, now question is afferent arteriole, if it is dilated, who is causing the afferent arteriolar dilation? Afferent arteriolar dilation is done with the help of prostaglandins. Prostaglandins cause afferent arteriolar dilation, so they increase the GFR. Who causes the afferent arteriolar constriction? Who causes afferent arteriolar constriction? Adenosine, norepinephrine. Okay. Next, efferent arteriolar constriction. Efferent arteriolar constriction. Who is going to cause the efferent arteriolar constriction? Efferent arteriolar constriction is done with the help of angiotensin II. Angiotensin II causes efferent arteriolar constriction, biphasic response. And who causes the efferent arteriolar dilation? Drugs like ACE inhibitors. Okay, drugs like ACE inhibitors. So done. So changes in the GFR topic is completed. How the GFR is going to change. Now let's discuss about the parts of nephrons and important points. In one slide itself, we will discuss all the important points, parts of nephrons. Now look. Here is the Bowman's capsule. Here is the proximal convoluted tubule. Let's say this is descending limb of loop of Henle. Ascending limb of loop of Henle. Distal convoluted tubule. And here is the collecting duct. Okay, here is the collecting duct. Now, let's see important points one by one. Let's begin with the PCT. Maximum substances are reabsorbed in. Maximum substances are reabsorbed in the PCT. Most of the substances are reabsorbed in the PCT. Okay, except magnesium. Except magnesium. Most of the substances are reabsorbed in the PCT. In the PCT, glucose is reabsorbed. True. How much percent? 100% of the glucose is reabsorbed in the PCT. No doubt in that. 100% of the glucose is reabsorbed into the PCT. With the help of a transporter called as, SGLT2. With the help of this transporter called as SGLT2, all the 100% glucose is reabsorbed. Okay. So, this what is SGLT2? SGLT stands for sodium glucose cotransporter. So the point which I want you to know is the glucose is getting reabsorbed. No doubt in that. Glucose is getting reabsorbed only along with sodium. Glucose is reabsorbed along with the sodium. So sodium goes in, along with that glucose will go. So that's why the name sodium glucose cotransporter type 2. So tell me, glucose reabsorption is dependent on glucose reabsorption dependent on sodium. Okay, sodium. SGLT transporter type 2 is present in PCT. SGLT transporter type 2, yes, it is transporting sodium. It is also transporting glucose. So it's an example of which type of transport. Is it a simple diffusion, facilitated diffusion, primary active transport, secondary active transport. Okay, or is it osmosis? What kind of transport? This SGLT, see wherever you see the word SGLT standing with the letter S, starting with the letter S. So it's an example of secondary active transport. So the glucose reabsorption, in the PCT. The glucose reabsorption in the PCT is an example of secondary active transport. 100% glucose is reabsorbed. Okay. Now, in the PCT, yes, of course, 70% of water will be reabsorbed. 70% of sodium chloride will be reabsorbed, NaCl. So, what happened to the urine osmolarity? What happened to the urine osmolarity? Urine osmolarity or the urine concentration increases or decreases? See, the solute, that is the water, sorry, not solute, the solute, the sodium chloride. Solutes are reabsorbing 70%. Water, that's the solvent, reabsorbs 70%. So, solutes and solvents are reabsorbed in the same amount. The concentration of the urine will not change. The osmolarity of the urine is not going to change. So, urine osmolarity remains constant or same as plasma. Okay, so are isotonic to plasma, same things, isotonic. Okay, isotonic to plasma. So these are the important points about the PCT. So tell me, in the PCT how much water is reabsorbed? 70% water, 70% sodium chloride, 100% of the glucose will be reabsorbed. The glucose reabsorption is an example of secondary active transport with the help of SGLT2. So tell me, SGLT2 is present in PCT. Okay, so in PCT, maximum substances are getting reabsorbed except magnesium. Now the water reabsorption, 70% water reabsorption that is happening in the PCT, it is called as obligatory. Water reabsorption. Okay, obligatory water reabsorption. Now in your PCT, in you and me, maximum glucose will be reabsorbed, no doubt in that. Okay, every single molecule of glucose will be reabsorbed, but everything will have a limit. If you are putting more and more glucose in diabetic people, if you are keeping more and more glucose, do you think all the glucose molecules will be reabsorbed? No, it's not possible. So how much is the transport maximum value for the glucose? How much maximum glucose can be reabsorbed? Okay, so that is also an important MCQ. That transport maximum, Tmax, the transport maximum value for the glucose is 375 milligrams per minute. Okay, till this much value, till this much amount of glucose will be reabsorbed by all the nephrons together, every minute. How much glucose they can take back into the body, they can reabsorb back into the body? 375 milligram per minute. Beyond this, your nephrons cannot reabsorb. The Tmax value for the glucose is 375 milligrams per minute. Okay, so PCT important points completed. Next, the descending limb of loop of Henle. In the descending limb of loop of Henle, only water is reabsorbed. Okay, only water is getting reabsorbed. Via which process? Osmosis. Okay, via osmosis water is getting reabsorbed. As the water is getting reabsorbed, tell me what happened to the urine concentration? Here the urine is going to get concentrated. Okay, so this descending limb of loop of Henle, this is the descending limb of loop of Henle. Now descending limb of loop of Henle, only water is getting reabsorbed, no solutes are reabsorbed. No, let me write here, no solute reabsorption, no solute reabsorption. That is no sodium chloride reabsorption. Only water is getting reabsorbed. As only water is getting reabsorbed, the urine is getting concentrated. So this is called as concentrating segment of nephron. Okay, so this is called as a concentrating segment of the nephron because the urine is getting concentrated. Okay, now look at this area. So this segment of the nephron, the sodium chlorides are getting reabsorbed. Okay, so sodium chloride will be reabsorbed back into the medulla. Okay, sodium chloride will be reabsorbed. With the help of a transporter, there is a transporter. This is important. There is a transporter in the ascending limb of loop of Henle. Okay, in the ascending limb of loop of Henle, there is a transporter with which the sodium chloride are getting reabsorbed. No, water is not getting reabsorbed. Only sodium chloride is getting reabsorbed. This transporter is called as, the name of this transporter is sodium potassium 2 chloride importer. Okay, there is something called as a sodium potassium 2 chloride importer. With the help of it, sodium chloride will be reabsorbed into the medulla. Okay. Now, what else they can ask you is, say, in the ascending limb of loop of Henle, in this ascending limb of loop of Henle, as the sodium chloride is getting reabsorbed from the urine, urine you are taking out the sodium, you are taking out the chloride. So what happened to the urine? The urine is getting diluted. The urine, it is getting diluted. See, it is 1200 initially. It is kept on getting diluted. At the end, it is getting diluted. Okay, so it is a diluting segment. Okay, so descending limb is the concentrating segment, ascending limb is the diluting segment. Descending limb is only permeable to water, ascending limb is only permeable to solutes. Okay, what else you should know? Ascending limb of loop of Henle, it is having which charge? It is having positive charge. Ascending limb of loop of Henle is having positive charge. Why there is this positive charge? Because in the ascending limb of loop of Henle, potassium is secreted into the ascending limb of loop of Henle, who is always secreted 24/7 throughout the day. The potassium is kept on secreted. So because of this potassium, you know, potassium is a positive charge. Because of that, the ascending limb of loop of Henle is having positive luminal potential. It is having positive charge. Ascending limb of loop of Henle is having positive charge due to secretion of potassium. What else you should know for your exam? Sir, what is the transporter that I have spoken with you? There is an important transporter through which the sodium chloride are getting reabsorbed. What is the name of this transporter? Sodium potassium 2 chloride importer, right? The sodium potassium 2 chloride importer, it is inhibited with the help of a drug. It can be blocked by, it is blocked by which drug? Which drug? Loop diuretic. It is blocked by which drugs? Loop diuretics. Okay. In some individuals, this sodium potassium 2 chloride importer, it is mutated. It is mutated by birth itself. It is non-functional by birth itself. If it is mutated, that's going to cause a syndrome that is called as Bartter syndrome. Okay, if the sodium potassium 2 chloride importer, if it is not functioning from birth itself, then it is going to cause Bartter syndrome. Okay, so these are some important points. So tell me, Bartter syndrome, which segment of the nephron is affected? In Bartter syndrome, it's the ascending limb of loop of Henle is affected. The sodium potassium 2 chloride importer is affected. Okay, ascending limb of loop of Henle is having positive luminal charge. In the ascending limb of loop of Henle, potassium is getting secreted. The ascending limb of loop of Henle is having sodium potassium 2 chloride importer. Ascending limb of loop of Henle is a diluting segment for the urine because the urine is getting diluted. Ascending limb of loop of Henle is only permeable to solutes, not solvents. Okay, so these are the important points about the ascending limb of loop of Henle. Now let's discuss about the distal convoluted tubule, DCT. Now look at here, on the DCT I am showing you one cell, one epithelial cell. Okay, this is the one epithelial cell. Here there are 4 transporters present. This is transporter number 1, transporter number 2, transporter number 3, transporter number 4. Okay, there are 4 transporters on this epithelial cell of distal convoluted tubule. What is this first transporter doing? The first transporter is taking sodium into the cell along with chloride. So it is sodium chloride importer. What is the name of this transporter? Sodium chloride importer. You know it. What is the second transporter? This is a calcium channel. It reabsorbs the calcium. It is a TRPV5 calcium channel. It's a calcium reabsorbing channel. Okay. Next, what is this transporter? This pink transporter, it is taking 3 sodium. Sorry, it is throwing 3 sodium out of the cell. It brings 2 potassium into the cell. So this is sodium potassium pump. Sodium potassium pump. The last transporter, what is it doing? It brings the sodium into the cell. It exchanges the calcium into the blood. So this is sodium calcium exchanger. Sodium calcium exchanger. It brings the sodium into the cell in exchange for the calcium. Okay, sodium calcium exchanger. So 4 transporters are present. Questions which will come in your exam is, first, there is a drug called as thiazide diuretic. Where it will act? Thiazide diuretic acts on DCT. And which transporter? Thiazide diuretics acts on this sodium chloride symporter and inhibits them. Okay, and inhibits this transporter. So thiazide diuretics inhibits sodium chloride symporter. MCQ. Next, in certain individuals, the sodium chloride symporter is mutated from birth itself. It is mutated from birth itself. If the sodium chloride symporter, if it is mutated from birth itself, it is going to cause which syndrome? Gitelman syndrome. Okay. Next, what else you should know for your exam? Gitelman syndrome is a condition where there is defect in DCT. Okay. In Gitelman syndrome, which transporter is affected? Sodium chloride symporter. There is a hormone called as a parathyroid hormone. Look, parathyroid hormone. Now, where is this parathyroid hormone acting? The parathyroid hormone, it helps in increasing the calcium levels in your blood. You already know it. It increases the calcium levels in your blood. Parathyroid hormone activates this transporter. Okay, parathyroid hormone, what it will do? Parathyroid hormone is going to activate the sodium calcium exchangers. So more and more calcium will be reabsorbed. So what happened to the calcium levels in the blood? Calcium levels increases. So tell me, parathyroid hormone acts on which part of the nephron? Parathyroid hormone acts on, yes, DCT. It increases the calcium levels by increasing the activity of sodium calcium exchanger. Okay. Now, having said that, I will tell you 2 important pharma related things. Anyway, you know it. Loop diuretics. If I am talking about the loop diuretics, what they will do with the calcium levels in the body? Loop diuretics decreases the calcium levels in your body. Thiazide diuretics, they increases the calcium levels in your body. Okay, so loop diuretics will loop out the calcium from your body. Loop diuretics decreases the calcium levels, but the thiazide diuretics, they increases the calcium levels. So both the disorders I have completed. The loop diuretics is Bartter syndrome and Gitelman syndrome. Bartter syndrome is a disorder of ascending limb of loop of Henle, and Gitelman syndrome is a disorder of distal convoluted tubule, guys. Okay, now so we have completed the PCT, loop of Henle is completed, and the distal convoluted tubule also completed. Now let's discuss about the last part of the nephron, that is the collecting duct. Now I am talking about this part. It's a collecting duct. So I am going to show you the collecting duct, only the collecting duct here. So let's say this is the collecting duct. On the collecting duct, there are 2 types of cells present. One is called as the principal cell. The other is called as the intercalated cell. This is the intercalated cell. Okay, intercalated cell, IC. Principal cell, intercalated cell. Now, who is going to act on this principal cell? Hormone called as aldosterone. The aldosterone, it's a steroid. In the name itself, it's a steroid. Aldosterone, it crosses the cell membrane. It is going to bind with its receptor in the cytoplasm. So aldosterone have which receptor? Intracytoplasmic receptor. MCQ. Intracytoplasmic receptor. When aldosterone is acting on this principal cells, do you know what these principal cells will do? Now principal cells will produce this channel through which the sodium will be reabsorbed into the cell. So this channel name is called as ENaC, epithelial sodium channel. Epithelial sodium channel. And the same cells will also produce one more channel through which they will secrete the potassium out. Okay. So what is the function of aldosterone? Tell me. Aldosterone helps in sodium reabsorption with the help of epithelial sodium channels. And the same aldosterone is going to kick out the potassium out of the cell, excretion or secretion of potassium. True. And this aldosterone will also act on these intercalated cells. When aldosterone is acting on the intercalated cells will kick out the protons. So proton excretion, acid excretion. So tell me, aldosterone is having how many functions? Aldosterone is having 3 functions. One is sodium reabsorption, potassium excretion, and proton excretion. These are the three functions of aldosterone. What is the major stimulus for the release of aldosterone? When the aldosterone will be released? It's not the RAS pathway. What is the major stimulus? It's the hyperkalemia. Okay, hyperkalemia. Hyperkalemia means what? More potassium, more than 5.5 millimoles per liter. If you're having more potassium, that's bad. It can cause arrhythmias, right? So, more potassium is going to trigger the release of aldosterone. And what is aldosterone doing? Aldosterone will kick the potassium out of the body. So, hyperkalemia is a major stimulus for aldosterone. Okay. Now, tell me, this epithelial sodium channels, they are under the control of which hormone? They are under the control of aldosterone. Whenever there is aldosterone, then this epithelial sodium channel should work. But what if this epithelial sodium channels are doing overaction, overactivity? This epithelial sodium channel overactivity, which means aldosterone is not there, but still they are functioning. They are reabsorbing sodium reabsorption. So epithelial sodium channel overactivity is going to cause a syndrome called as Liddle syndrome. So Liddle syndrome is due to epithelial sodium channel overactivity. Okay. Next, let's discuss about one more hormone. Same, I am talking about the same nephron collecting duct. This is collecting duct. Here I am talking about the same principal cell. But right now I am talking about a different hormone, that is antidiuretic hormone, ADH, antidiuretic hormone. Now this antidiuretic hormone, it is going to act on its receptor called as a V2 receptor. The antidiuretic hormone will come and act on this V2 receptor. But question is, what is the stimulus for the release of antidiuretic hormone? What is the stimulus for the release of this antidiuretic hormone? The stimulus is hypertonic plasma. So hypertonic plasma is the stimulus for the release of antidiuretic hormone. What is this antidiuretic hormone is doing? Antidiuretic hormone will come and binds with the V2 receptor. Now once this V2 receptor is activated, now do you know what will happen? Now these principal cells will produce these channels through which the water will be reabsorbed into the body back. Okay, water will be reabsorbed into the body back from the urine. Okay, so this channel is called as aquaporin 2 channel. Aquaporin 2 channel. So tell me, hypertonic plasma is going to stimulate the release of antidiuretic hormone. Antidiuretic hormone will stimulate the V2 receptors. The stimulation of the V2 receptor is going to incorporate the aquaporin 2 channels. With the help of aquaporin 2 channels, only pure water is getting reabsorbed. This is called as solute free water reabsorption. Okay, because see, here the sodium is not getting reabsorbed, pure water is getting reabsorbed. This is called as solute free water reabsorption. Okay, solute free water reabsorption, or you can also say this is called as facultative water reabsorption. Again, I am reminding you, obligatory water reabsorption. Obligatory water reabsorption occurs in the PCT. I have told you, it's an obligatory water reabsorption. In the PCT, you are having obligatory water reabsorption. In the collecting ducts, with the help of the antidiuretic hormone, there is a facultative water reabsorption. Okay. Let's say, what if this antidiuretic hormone is not there? If the antidiuretic hormone is not there means, do you think water will be reabsorbed? No, water is not going to be reabsorbed. All the water will be lost in the urine. More and more water will be lost in the urine. So the patient is going to have more urination or less urination? More urination. More urine. So that is called as diabetes insipidus. Okay, diabetes insipidus. What is the problem with the diabetes insipidus? Antidiuretic hormone is not there, or this V2 receptor is not functioning. Either the V2 receptor resistance or the loss of antidiuretic hormone. If both these two things are not there, means the patient is going to produce more and more urine, diluted urine. So that is called as diabetes insipidus. Okay, insipidus. Now what if there is more antidiuretic hormone? Can you tell me what is The condition where there is more antidiuretic hormone. If more antidiuretic hormone is there means, tell me, more antidiuretic hormone is there. Why there is more antidiuretic hormone? It is seen with small cell carcinoma of lung. The small cell carcinoma of the lung, in a condition called as a small cell carcinoma of the lung, there is more antidiuretic hormone. This antidiuretic hormone is going to stimulate the V2 receptors continuously. The continuous stimulation of the V2 receptors is going to reabsorb more and more water. So more and more water will be reabsorbed with the help of aquaporin 2 channels. So tell me, as more and more water is getting reabsorbed, what happened to the urine amount? Less urine. Okay, so now patient is going to produce less urine, the two concentrated urine, because water is not there. There is more sodium in the urine, concentrated urine, hypertonic urine. This condition is called as SIADH. So what is SIADH? SIADH means the syndrome of inappropriate antidiuretic hormone synthesis. The syndrome where inappropriately more and more antidiuretic hormone is kept on getting produced. Okay, more and more antidiuretic hormone is kept on getting produced. That is syndrome of inappropriate antidiuretic hormone synthesis, where the patient is going to produce concentrated urine. So tell me, where all this water is going? All this water is going back into the body. At the end of the day, with the help of the peritubular capillaries, all this water will go back into the circulation. So now tell me, when the more and more water is going back into the body, what happened to the blood concentration? The blood is getting diluted. The blood is getting diluted because the water is not coming out of the body. There is water retention. So the person is going to have dilutional hyponatremia. So in your exams question may be asked, dilution hyponatremia. Dilutional hyponatremia is going to be seen with SIADH. So more antidiuretic hormone is there, right? In this condition, more and more antidiuretic hormone is there, more V2 receptor stimulation is there. So how to treat this condition as a doctor? You have to block these V2 receptors. So V2 receptor blockers, V2 blockers will be used in the treatment of SIADH. So V2 blockers, what are the V2 blockers? Vaptans. Drugs called as vaptans like tolvaptan, conivaptan. So tolvaptan, conivaptan, these are the drugs which are V2 blockers which are going to be used in the treatment of SIADH. The same way, I have explained you about this Liddle syndrome, right? Liddle syndrome. What is Liddle syndrome? Overactivity of this epithelial sodium channel. This epithelial sodium channels, they are doing overaction. So how to treat this condition? Block the epithelial sodium channels. You can block the epithelial sodium channels. What is the drug that will block the epithelial sodium channel? So ENaC blocker. ENaC blocker is amiloride. Okay, amiloride is a ENaC blocker which will be used in the treatment of Liddle syndrome. Okay, vaptans are used in the treatment of SIADH. Now some students will have a doubt. Sir, then the treatment of diabetes insipidus. What is the treatment? What is the treatment of diabetes insipidus? See, I have told you two reasons for the diabetes insipidus. One is either the antidiuretic hormone is not there, or the V2 receptor is not functioning. Okay, two reasons I have told you. So let me write here. Reason number one is antidiuretic hormone nahi hai. It's not there. If antidiuretic hormone is not there, it causes diabetes insipidus. Which type of diabetes insipidus? Central diabetes insipidus. It is treated by giving desmopressin. In the second condition, the V2 receptor resistance is there. That will cause nephrogenic diabetes insipidus. It is treated by giving thiazide diuretics. So that's it. So all the important diseases I have completed. Liddle syndrome, like we have completed about the SIADH, we have completed Bartter syndrome, Kittelman syndrome. The important points we have completed. Now in the renal physiology, the last, the most important topic is cystometrogram. Okay, so cystometrogram. Okay, highly anticipated area, cystometrogram. So what is this cystometrogram? Cystometrogram is going to tell you the volume changes and the pressure changes in the urinary bladder. The volume changes and the pressure changes in the urinary bladder. So here I am talking about the volume. Okay, here I am talking about the bladder pressure. See, when the urine is coming into the bladder, see 5 ml, 10 ml, 20 ml, what happened to the pressure in the bladder? You tell me. The pressure in the bladder also increases. Okay, let's say this is the initial phase. See, when the volume is increasing, also pressure is increasing little bit. The pressure is also increasing. Volume increases, pressure also increases. Okay, this is phase 1A. Okay, what is this phase 1A? Bladder filling started. Okay, bladder filling started. Now, with the amount of upcoming urine, with the amount of urine coming into the bladder will also distend. Okay, bladder is not a rigid thing. It's not a stone like thing. It's a flexible thing. It's going to stretch. So bladder is now stretching to accommodate the urine. So that's why as the bladder is stretching, the pressure within the bladder is not rising. The pressure within the bladder is almost maintained constantly. So now look, the pressure in the bladder for some time it's almost maintained constantly. This is phase 1B. This is phase 1B. Okay, what is happening in phase 1B? There is distension of bladder. Distension of bladder. Okay, in your exam they will mainly concentrate on this phase 1B, or they can say some other phase 1B instead of phase 1B they can say B also, simply B. Okay, or they can say phase 2. What is happening in this phase 1B? There is a distension of bladder. Our phase 1B is explained by bladder plasticity. Bladder is highly plastic, easily stretchable. So phase 1B is explained by plasticity of bladder. Okay, bladder plasticity. Okay, next they will ask you the pressure in the bladder is almost maintained constant. It is explained by which law? Explained by law of Laplace. Okay, it is explained by law of Laplace. Now once the bladder is having 400 ml of urine, now there is a sharp rise in the pressure. There is going to be a sharp rise in the pressure, means you are going to have a sharp urge. Okay, you are going to have a strong urge for urination. You can't hold the urine, you will go for the urine. You are going to have a sharp urge for the urine. So tell me how many phases are there? There is phase 1A, phase 1B and phase 2. At which volume there is a sharp rise in bladder pressure? 400 ml. At somewhere around 150 ml, you will have the first feeling for the urination. The first urge to go for the urination happens, first urge at 150 ml. Okay, 150 ml. So this is all about the cystometrogram. In cystometrogram, the phase 1B is important. Phase 1B is due to plasticity of bladder. Phase 1B is explained by the law of Laplace, where the pressure in the bladder is not rising but maintained constantly. Okay, cystometrogram also completed. Now here in renal physiology, the last thing that I will explain you is the acid-base balance. Here in acid-base balance, look, this is the last part of the nephron. Okay, there are many ways by which the kidney is going to maintain your pH, like by producing the new bicarbonates, by reabsorbing the already existed bicarbonates. Okay, there are many ways, but mainly look here, this is the collecting duct. Look, this is the collecting duct. Whenever there is acidosis, look, let's say there is acidosis. On one side I am showing acidosis. When the patient is having acidosis, this intercalated cell, look, this intercalated cell, You tell me, during acidosis, do you want any acids in your body? Do you want any H plus ions, acids in your body? No. So this intercalated cell, what it will do is it will excrete the H plus. It is excreting the acid. So this acid excreting cells are called as alpha intercalated cells. So alpha intercalated cells are acid excreting cells. Alpha intercalated cells are the acid excreting cells which are seen during acidosis state. During acidosis, we don't want acids, so we have to excrete the acids. Done. Next, there is one more intercalated cell. During the time of alkalosis, okay, during the time of alkalosis, which means your pH is more pH 7.5, like more than 7.45. What it will do is it will excrete the bicarbonates, okay, which is base excreting. Okay, it's a base excreting cells, bicarbonate excreting cells. They are called as beta intercalated cells. So there is something called the alpha intercalated cell which are acid excreting seen during acidosis states, and there is something called as the beta intercalated cells. Beta intercalated cells are seen during alkalosis. B for B, beta are base excreting. So whenever there is acidosis or alkalosis, by excreting the acids and bases, your kidneys can maintain your pH to certain degree. Okay, so this is the important point which I want you to know. With this, the renal physiology is also completed. Now I will give you a break of 5 minutes. Again, later we will be discussing about endocrine physiology and GAT. Okay, endocrine physiology and GAT will be discussed after 5 minutes. So let's have a break of 5 minutes. Break. Okay, guys. Let's continue with the endocrine physiology. After cardiovascular physiology, you can anticipate maximum questions from the endocrine physiology, because endocrine we are going to deal with a lot of hormones, so automatically weightage is also going to be more because it's highly integrated with the medicine as well as the pathology. So having said that, now in endocrine physiology, let's say this is one cell. Okay, this is one cell. It is producing certain chemicals. These chemicals are coming back and acting on the same cell. Okay, maybe inhibiting, maybe stimulating. So one cell is producing certain chemicals and these chemicals are right away coming back and acting on the same cell. This is called as which type of signaling? This is called as autocrine signaling. Okay, this is called as autocrine signaling. Or let's say there is some other cell which is producing certain chemicals. They are coming and acting on an adjacent cell. Okay, they are coming and acting on adjacent cell. So this is which type of signaling? This is called as a paracrine signaling. Paracrine signaling. Here, let's say there is one cell. It is producing certain chemicals. These chemicals are getting access into the blood vessel. They are entering into the blood vessel, and through the blood, they are coming and acting on a distant cell. It's present somewhere far away, and these chemicals are coming and acting on a distant cell. This type of signaling is called as endocrine signaling. This is called as the endocrine signaling. So there are different types of cell signaling. One is autocrine. I have shown you a cell acting on itself. Okay, autocrine, paracrine, and endocrine. Autocrine, paracrine, and endocrine. These are the three different types of signaling. After this, the next important area which I want you to know is secondary messengers. What are the three important secondary messengers? CAMP, cyclic AMP. So cyclic AMP is used by or produced by which hormones? Cyclic AMP is a secondary messenger produced inside the cells by which hormones? Cyclic AMP is produced by FSH, LH, TSH, ACTH, these hormones. Next, histamine, antidiuretic hormone acting on V2 receptor, histamine acting on H2 receptor. Okay, beta HCG, norepinephrine. Okay, based on the receptor, that's a totally different thing. But anyway, FSH, LH, TSH, ACTH, histamine acting on H2 receptor, antidiuretic hormone acting on V2 receptor, beta HCG, norepinephrine. All these hormones, when they act on the cell, okay, when they act on the cell, they increases the level of a CAMP. Okay. Next, CGMP, cyclic GMP. Cyclic GMP is a secondary messenger produced inside the cell. When the cell is acted upon by which hormones? That is atrial natriuretic peptide or brain natriuretic peptide, ANP or BNP, nitric oxide. So this is very, very important. Nitric oxide, when it's acting on the cell, nitric oxide increases the level of cyclic GMP. Okay, so nitric oxide, atrial natriuretic peptide, they increases the which secondary messenger? CGMP. And the third secondary messenger is IP3. So IP3 stands for inositol triphosphate. It's a secondary messenger. Yes, it is used by which hormones? The IP3 levels inside the cells are increased when the cells are acted upon by which hormones? Oxytocin. Okay, oxytocin, antidiuretic hormone acting on V1 receptor, histamine acting on H1 receptor, angiotensin 2, okay. So oxytocin, antidiuretic hormone, histamine, angiotensin 2, all of them, they will increase the IP3 levels inside the cell. One of the important function of the IP3 is to increase the intracellular levels of calcium, and with the help of this calcium, the muscles will be contracting. Okay, you know oxytocin, what is the function of oxytocin? Uterine contraction. What is the function of antidiuretic hormone? Antidiuretic hormone, also called as a vasopressin, causes vasoconstriction. Histamine, bronchoconstriction, for that you require muscles. Angiotensin 2 causes a vasoconstriction, for that you require the muscles. So IP3 is a secondary messenger which is produced in the muscles. Okay, especially when they are acted upon by oxytocin, angiotensin 2, histamine, antidiuretic hormone. So IP3 is something causing the contraction or constrictions. Anything, wherever you see the word contraction or constrictions, there the secondary messenger that is going to be produced is the IP3. Okay, so that's it. So how many secondary messengers are there? CAMP, CGMP and IP3. These are the secondary messengers. Which secondary messenger increase the intracellular levels of calcium? IP3. Now after this, next what I want you to know is there is something called as a tyrosine kinase receptors. So the tyrosine kinase receptor is used by which hormone? The tyrosine kinase receptor is used by insulin and growth factors, not growth hormone, growth factors. Okay, so tyrosine kinase receptor is used by which hormone? Insulin. It's a repeatedly asked question, and growth factors. And there is something called as a JAK-STAT pathway. JAK-STAT pathway. Okay, JAK-STAT pathway. It's a signal transduction pathway. Janus kinase signal transduction and activator of transcription. It's a pathway. This JAK-STAT pathway is used by which hormones? It is used by which hormones? That is growth hormone, not growth factor, growth hormone. Prolactin and leptin. Okay, these hormones they use as the JAK-STAT pathway. See, I want you to know some important points regarding the leptin. So leptin is the one which decreases your hunger. It decreases your hunger. It gives you the feeling of fullness, that is satiety. It gives you the feeling of satiety. So it is anorexigenic hormone. Anorexigenic hormone means it decreases the hunger. From where this leptin is getting produced? Leptin is produced by the adipocytes. Okay, leptin is getting produced from the adipocytes. So JAK-STAT pathway is used by which hormone? Growth hormone and prolactin. The growth hormone and prolactin, they are called as the twin hormones. Okay, they are called as the twin hormones. Now, after discussing about the different secondary messengers and some important receptors and pathways, now let's discuss about the hypothalamus and pituitary gland. Okay, let's say this is the hypothalamus and here is the pituitary gland. Okay, I'm going to talk mainly about the important hormones, important hormones. See guys, here there is a nucleus present. In the hypothalamus there is a nucleus present. This nucleus is producing something called as a GnRH, gonadotropin releasing hormone. Gonadotropin releasing hormone. This gonadotropin releasing hormone is going to come and act on gonadotropes. These gonadotropes. Now these gonadotropes, when they are acted upon by GnRH, they are going to produce FSH, LH. They are going to produce what? FSH, LH. Okay, these gonadotropes, let me erase here so that I can write some extra information. So these gonadotropes, let me write GT, are going to produce FSH, LH. Now what is the function of this FSH, LH in the females? Now in the females, this FSH is going to act on the ovaries. They are going to act on especially cells called as the granulosa cells of ovaries. Granulosa cells of ovaries. So these granulosa cells, when they are acted upon by FSH, they are going to produce estrogen. Okay, estrogen. Now remember till the time of your exam that FSH main function is to produce estrogen. Now this estrogen, say what are the functions of this estrogen? Number one function is, once you have sufficient amount of estrogen, the estrogen will give negative feedback to FSH. Estrogens will give negative feedback to FSH, true. This estrogen helps in breast development. Estrogen help in endometrial growth. Okay, endometrial proliferation. The same estrogens are going to act on the bones, causes the inhibition of the growth, closure of epiphyseal plate. Estrogens causes closure of epiphyseal plate. Means growth inhibition is because of estrogen. So tell me, FSH helps in estrogen production. Estrogen is coming from which cells? Granulosa cells. Now what is the function of this LH then? LH causes ovulation. Once you have ovulation, what do you have? The developed follicle. The developed follicle is going to rupture and releases the ovum. This is a ruptured follicle. Okay, once the ovulation is done, you are having a ruptured follicle, right? This ruptured follicle will become corpus luteum. Because of the ovulation, there is development of corpus luteum. Now this corpus luteum is going to produce progesterone. Okay, progesterone. Now this progesterone, it helps in the pregnancy. It's a progestational hormone. It maintains the endometrium. A lot of good things are there. Okay, but who is giving negative feedback to LH? Progesterone. So estrogens give negative feedback to FSH and progesterone gives negative feedback to LH. Now let's talk in males. See, in males, what are the gonads? Testis is the gonad. Testis is the gonad. In testis, there are two types of cells present. One is Sertoli cell, other one is Leydig cell. Now look here, this FSH is coming and acting on the Sertoli cells. Okay, FSH is acting on which cell? Sertoli cell. When FSH is acting on the Sertoli cell, these Sertoli cells produce something called as inhibin B. The B for boys. Inhibin B is produced by the Sertoli cell. This LH is acting on Leydig cell. L for L. LH is acting on the interstitial cells of Leydig. When LH is acting on the Leydig cell, it is the Leydig cells which produce testosterone. Okay, testosterone. Some important points. Say, Sertoli cells produce inhibin B. Okay, this inhibin B gives negative feedback to FSH. Inhibin B is going to give the negative feedback to FSH, no doubt in that. Okay, let me make it little clear for you so that it will be easy. FSH and LH. FSH, LH. LH is going to act on Leydig cells. This inhibin B gives negative feedback to FSH. Testosterone gives negative feedback to LH. Okay. These Sertoli cells not only produce inhibin B, but they also produce something called as anti-Mullerian hormone. Okay, anti-Mullerian hormone. These Sertoli cells, they are forming a structure, anatomical structure called as blood testicular barrier. Okay, they forms the blood testicular barrier. It's the Sertoli cells which forms the blood testicular barrier. Sertoli cells are the real mother-like cells. They are the nursing cells which helps in spermatogenesis. Okay, these are the important points about the gonadotropic hormones, that is FSH, LH in the males. You know, testosterone with the help of enzyme called as 5-alpha reductase. 5-alpha reductase will be converted into more powerful testosterone called as dihydrotestosterone. Dihydrotestosterone. Okay, with the help of enzyme called as 5-alpha reductase. This dihydrotestosterone, in your pathology, you have studied this dihydrotestosterone, especially after 60 years of age. In males, they will cause the prostatic hyperplasia. Okay, causes benign prostatic hyperplasia. Okay, benign prostatic hyperplasia, that's a BPH, is a non-cancerous condition. So benign prostatic hyperplasia is due to dihydrotestosterone, okay, which is the more potent form of testosterone. Okay, so these are some important points which I want you to know. Next, say here, let's say this is the hypothalamus. Here is the hypothalamus. Here is the pituitary gland. Now, because of trauma, the pituitary gland is severed. Okay, the pituitary gland is severed. Now, there is damage to pituitary stalk. I should say the pituitary stalk is severed. Okay, cut. Okay, the pituitary stalk is damaged. Now, when the pituitary stalk is damaged, what happens? Do you know? All the anterior pituitary hormones, all anterior pituitary hormones decreases. All the anterior pituitary hormones decreases except one hormone, except prolactin. Actually, prolactin levels increases. So tell me, if a pituitary stalk is damaged in a person, the pituitary stalk is damaged, all the hormones are going to decrease except prolactin. Some important points about the prolactin is, so who inhibits the prolactin? Who decreases the prolactin? It's the dopamine. It's the dopamine. So dopamine is a physiological antagonist of prolactin. It decreases the prolactin level. Okay. Next, one more condition. Look at here. Let's say here is the hypothalamus. Here is the pituitary gland. Let's say mainly anterior pituitary. The whole pituitary gland have undergone necrosis. Okay, whole pituitary gland have undergone necrosis. In whom it will undergo necrosis? Especially in those females who have delivered a baby with a complication of postpartum hemorrhage. Okay, so this is a postpartum necrosis of pituitary gland. Postpartum, after delivering the baby, this female is having a complication of postpartum hemorrhage, PBH. The postpartum necrosis of pituitary gland is called as Sheehan's syndrome. Okay, Sheehan syndrome. In Sheehan syndrome, the entire pituitary gland is gone. Entire pituitary gland is gone. So all hormones decreases. Even prolactin, the growth hormone, prolactin, TSH, ACTH, FSH, LH, all the anterior pituitary hormones decreases. Okay. So the point is, see, postpartum, actually after delivering the baby, the female have to lactate the baby. The female have to give the milk to the baby. But do you think this female can lactate? No. There is failure to lactation. There is failure to lactation. These females cannot lactate. Okay, right after delivery, because the prolactin is not there, because the entire pituitary gland is gone. So now let's discuss some important points about the milk. Okay, so it's the estrogens helps in mammogenesis, means the breast development. Okay, estrogens helps in the mammogenesis. That's the breast development, you know it. Next, it's the prolactin helps in milk production. That is lactogenesis. Okay. Next, it's the oxytocin which is helps in milk ejection. That is galactokinesis. Galactokinesis means milk let out. And there is something called as maintenance. Okay, both prolactin and oxytocin, both the hormones, prolactin and oxytocin, what they are doing, they are causing the milk production and ejection. There is maintenance. That is called as galactopoiesis. So they will ask you the order. In the recent FMGe exam, they have asked the order of events. Yes, mammogenesis, lactogenesis, galactokinesis and galactopoiesis. This is the order of lactation. Okay, so these are the points which I want you to know. Next, after this, I want you to know about the individual hormones. Individual hormones. Let's say growth hormone. Growth hormone is an anabolic hormone. Let's write AH, anabolic hormone. So what it will do with the carbohydrates, proteins and fats? So carbs, it increases the blood levels of glucose. Okay, it increases the blood levels of glucose. Okay, by causing the glycogenolysis. It increases the blood levels of glucose. Next, proteins. Growth hormone, anabolic hormones means build up of the body, body building. So protein synthesis. Proteogenesis, protein synthesis. And fats. That is the lipolysis. Okay, lipolysis. So growth hormone is going to increase your blood glucose levels, also the protein synthesis and lipolysis. See, as the growth hormone is increasing the blood glucose levels, can I say it as a hyperglycemic hormone? Yes, it's a hyperglycemic. Growth hormone is a hyperglycemic hormone. It can lead to, in high amounts, it can lead to hyperglycemia and diabetes mellitus. So can I say it's a diabetogenic hormone? Yes, it's a diabetogenic hormone. Yes, it's a diabetogenic hormone, no doubt in it. Okay, growth hormone. Who will give negative feedback to growth hormone? Let me tell you. Say, growth hormone, when you have sufficient amount, the growth hormone is going to go to the liver. It acts on the liver. Now, liver is going to produce something called as somatomedian C, also called as insulin-like growth factor 1. Insulin-like growth factor 1 or somatomedian C. So, this insulin-like growth factor 1 or somatomedian C is the one which gives the negative feedback to growth hormone. So, negative feedback to growth hormone is given by insulin-like growth factor 1 or somatomedian C. Next, who will stimulate the production of growth hormone? What are the conditions in which the growth hormone levels are going to be elevated? So, increase growth hormone. Which conditions are going to stimulate the growth hormone release? One is fasting. When you do fasting, who is going to produce in your body? Ghrelin. Okay, so fasting and ghrelin. Fasting and a chemical called as ghrelin. Okay, fasting and ghrelin, they increases the growth hormone. Yes. Next, exercise. Exercise. Trauma. Eating. Okay. Sleep. Glucagon. Testosterone. Estrogens. All these conditions, in all these conditions and all these hormones, glucagon, testosterone, estrogen, eating, sleep, trauma, exercise, fasting, ghrelin, all these conditions are going to increase the growth hormone level. Then who will decrease the growth hormone level? Growth hormone levels are decreased by, I have told you who will give the negative feedback to growth hormone. It is somatomedian C or insulin-like growth factor, or there is something called as somatostatin also. There is somatostatin. This somatostatin also decreases the growth hormone. So who increases the growth hormone? Who decreases the growth hormone? It's a question previously asked. Who increases the growth hormone was a previous year question. Okay. So important points, growth hormone done. Next, thyroid hormones. Thyroid hormones. What are the important thyroid hormones? T3 and T4. The T3 is active form. Active form. T4 is inactive form. T4 gives negative feedback. T4 have long half-life. How much long half-life? 7 days, almost a week. T4 have long half-life because it is mainly bound with plasma proteins. Which plasma proteins? Thyroid binding globulins. Previous year MCQ. So thyroid hormones mainly binds with a plasma protein called as thyroid binding globulin. T4 mainly binds with thyroid binding globulin, the plasma protein. Okay, the plasma protein. First of all, thyroid hormones, are they anabolic hormones or are they catabolic hormones? They are catabolic hormones. Okay, they are catabolic hormones. So as they are catabolic hormones, what they are going to do with the carbohydrates, proteins and fats? So catabolic, right? So breakdown. So carb metabolism is glycogenolysis. So increases the blood levels of glucose. What about the proteins? Proteolysis. Proteolysis. What about the fats? Lipolysis. Okay, it's a catabolic hormone. It's going to break down the things. But it also helps in the development of certain things. It helps in the development of central nervous system development, brain development. And the musculoskeletal system, MS, musculoskeletal system, it helps in the skeletal development. What else are the important functions of the thyroid hormone? Thyroid hormones, by acting on your cells, they increases your basal metabolic rate. They increases the amount of energy expenditure. If the thyroid hormones are acting on the cells will use more and more energy. Okay, they increases your basal metabolic rate. And not only that, thyroid hormones will increase your body temperature. Okay, they increases body temperature. That's why they are called as the thermogenic hormones. They are thermogenic hormones. So thyroid hormones, they are hyperglycemic hormones. They cause the proteolysis, they cause the lipolysis, they help in the brain development, skeletal development, increase the basal metabolic rate, they increase the body temperature. They are thermogenic hormones. Okay, so to produce these thyroid hormones, okay, from the raw materials, that is the iodine and thyroglobulin. Okay, from the raw materials you have to produce what? T3 and T4. These are the hormones. For the production of this T3, T4, you need to have an enzyme which is called as a thyroid peroxidase. With the help of this enzyme called as a thyroid peroxidase, you are producing T3, T4. So what is this thyroid peroxidase doing? It catalyzes three important steps. It catalyzes three important reactions. Those reactions are called as oxidation, organification, and coupling reaction. Okay, so there is an enzyme called as a thyroid peroxidase which is going to help in oxidation, organification, and coupling reaction. These three reactions are must and should needed for the production of T3, T4. So this the thyroid peroxidase can be inhibited with the help of a drug. The thyroid peroxidase can be inhibited with the help of a drug. They are carbimazole, methimazole, and propyl thiouracil. So carbimazole, methimazole, and propyl thiouracil are the drugs which can inhibit this thyroid peroxidase enzyme, and they can inhibit the production of T3, T4. They are anti-thyroid drugs. Okay. Next, what else you should know regarding the thyroid hormone? What else you should know is, guys, look, I have told you mainly it's the T4 that is producing the major thyroid hormone is the T4. Whenever it is required, it will be converted into T3. Wherever it is required and whenever it is required, it will be converted into active form, that is T3. Okay, so this conversion is called as a peripheral conversion. Okay, this is called as what? Peripheral conversion. This peripheral conversion is done with the help of an enzyme called as a deiodinase. Okay, it's going to occur with the help of an enzyme called as a deiodinase. So deiodinases, especially 5' deiodinases, will convert the T4 into T3 peripheral conversion. This peripheral conversion can also be inhibited with the help of certain drugs called as propranolol and propyl thiouracil. Okay, propranolol, propyl thiouracil, they are peripheral conversion inhibitors. They will inhibit the conversion of T4 into active T3. They are peripheral conversion inhibitors. They are used in the treatment of these drugs. Peripheral conversion inhibitors are used in the treatment of thyroid storm. Okay, thyroid storm. With this, important points about the thyroid hormone are completed. Now, let's say important points about insulin. Who produces this insulin? Insulin is produced by the beta cells of pancreas. Okay, beta cells of pancreas. These beta cells of pancreas, they not only produce insulin, but they also produce one more hormone called as amylin and one more substance called as C-peptide. Okay, C-peptide. Important points about the C-peptide are, see, for example, if beta cell produces 100 molecules of insulin, you can see 100 molecules of C-peptide in the urine. Means the amount of C-peptide and the amount of insulin produced will be equal in amount. So C-peptide it can be used to estimate the amount of insulin that is produced in the body. So C-peptide is a marker of endogenous insulin production, or I can say C-peptide is produced in equimolar concentration along with insulin. Okay, C-peptide is produced in equimolar concentration along with insulin. It's a marker of endogenous insulin production. Insulin, what kind of hormone it is? It's an anabolic hormone. The number one anabolic hormone in the body. Insulin is an anabolic hormone. Insulin, it is stored along with zinc ions inside the vesicles. It is stored along with zinc ions so that it have its proper structure. For the maintenance of the stability of the structure, you require zinc ions. Okay. Now, let's say some important points about the insulin. Okay, insulin. What is the function of insulin? Insulin, when it acts on tissues. Okay, when insulin is acting on the tissue, for example, let's say here is a blood vessel. Here is a blood vessel. Here is a tissue. I have told you what is the receptor for insulin? Tyrosine kinase receptor. See, this is the receptor. Okay. Now, this receptor is stimulated by insulin. When insulin is stimulating this receptor, now these cells, they will produce these channels for the first time, through which the glucose will be absorbed into the cell. What is the name of this channel? The name of this channel is glucose transporter type 4, GLUT4. So tell me, insulin, by acting on the tyrosine kinase receptor, is helping in incorporation of the glucose transporters type 4, so that now these tissues can absorb the glucose. Otherwise, no glucose absorption. Otherwise, no. Okay. So this glucose transporter type 4, they are transporting the glucose into the cell. Okay. They are example of which type of transport? Primary active, secondary active, simple diffusion, facilitated diffusion. It's an example of facilitated. So how I used to remember is a GF. Okay, GF. You know GF, right? So glucose transporters are examples of all glucose transporters. Type 1, 2, 3, 4, doesn't matter. All the glucose transporters are examples of facilitated diffusion. All the glucose transporters example of the facilitated diffusion. Okay. So glucose transporter type 4 is an example of facilitated diffusion. Done, guys. Now, these glucose transporters type 4, where are they present? These glucose transporter type 4, mainly they are present on which tissues? They are mainly present on adipocytes and skeletal muscles. They are mainly present on adipocytes and skeletal muscles. That's it. Okay. So insulin, anabolic hormone, acting on the tissues, mainly which tissues? Adipocytes and skeletal muscles, helping in the absorption of the glucose. Which type of transport? Example of facilitated diffusion. Some important points about the insulin. Some other important points. Say, insulin. The main function of insulin is to decrease the blood glucose levels. No doubt in that. It's have to decrease the blood glucose levels. How it is going to decrease the blood glucose levels? You know, the major function is by absorbing the glucose from the blood into the tissues. So the blood glucose levels decreases. What are the other mechanisms? What are the other ways by which the blood glucose levels comes down? Insulin is going to activate those biochemical reactions, going to activate those biochemical reactions which will decrease the blood glucose levels, like glycogenesis or glycogen synthesis. It is activated. Next, lipogenesis. What it will do? It will decrease the blood glucose levels. Next, glycolysis. See, all these biochemical reactions at the end of the day, what they will do? All these biochemical reactions at the end of the day, they will decrease the blood glucose levels. So they are all activated. And insulin is going to inhibit those biochemical reactions which increase the blood glucose levels. For example, see, it inhibits glycogenolysis, where it is increasing the blood glucose level, so it is inhibited. Next, gluconeogenesis, inhibited. It increases the blood glucose level, so it is inhibited. Okay. Next, lipolysis. I have told you it is stimulating the lipogenesis, so it inhibits the lipolysis. It inhibits ketogenesis. Okay, ketogenesis. Okay, so till the time insulin is there in the body, ketone bodies are not produced. Ketogenesis is inhibited. Remember the point. Next, other important functions about the insulin. Insulin, it moves potassium ions into cells in the presence of insulin. Okay, in the presence of insulin, what happened to potassium? Potassium will go into the cells, especially into the adipocytes. All the potassium will be uptaken by the adipocytes. So what is the relationship between the insulin and potassium? Insulin is going to move the potassium from the blood into the cells. Okay, so these are important points about the insulin. I have already explained you about aldosterone, how aldosterone is going to function on the nephron. Aldosterone is going to act on the principal cells, intercalated cells. That's three functions of aldosterone. Aldosterone is going to excrete the sodium, excrete the protons, and excrete the potassium. Okay, aldosterone, that's also a hormone that is already completed. Now, in the endocrine, what else you should know regarding the calcium homeostasis? Look here. Regarding calcium homeostasis, see, there are three important hormones. There is a parathyroid hormone, calcitonin, and vitamin D. Active form of vitamin D, also called as 1,25 dihydroxy polycalciferol, also called as calcitriol. Okay, these are all the same thing. Now, how these hormones are going to regulate the blood levels of calcium? The parathyroid hormone, what it will do to the blood calcium levels and what it will do to the phosphate levels. Okay, what it will do to the phosphate levels. See, parathyroid hormone is produced from the parathyroid glands. Parathyroid hormones increases the blood calcium levels, no doubt. But it's a phosphate trashing hormone. So it decreases the blood levels of phosphates. It kicks the phosphate out of the body. Okay. Now calcitonin, what it will do? Calcitonin produced from the thyroid gland. It is produced from the parafollicular cells. It's produced from the parafollicular cells of the thyroid gland. What is this calcitonin is going to do? Calcitonin decreases the blood levels of calcium, doesn't have any effect on phosphates. And this vitamin D, what is this vitamin D going to do? Vitamin D, it increases the blood calcium levels, also increases the blood phosphate levels. Okay, so the three important hormones and their effects on calcium and phosphate. So can I say something like this? Calcitonin and parathyroid hormone, they are physiological antagonists. Yes, so parathyroid hormone and calcitonin, they are having exact opposite action. One is going to increase the calcium, other is going to decrease the calcium. So parathyroid hormone, it's a hormone, not a vitamin. Parathyroid hormone and calcitonin, both are antagonistic hormones. Okay, so calcium homeostasis, these are the important points which I want you to know. The last thing that I want to discuss in the endocrine is regarding the cortisol. The last hormone is the cortisol. Cortisol, what kind of hormone it is? It's a catabolic. It's a catabolic hormone. Cortisol is a catabolic hormone. It's also called a stress hormone. So what it is going to do with the carbohydrates? You know it. It increases the blood glucose levels. Glycogenolysis is going to cause the increase in the blood glucose levels. Proteins, proteolysis. Regarding lipids, lipolysis. Okay. Same, some important points is cortisol. It's a steroid, right? Cortisol is a glucocorticoid. It's a steroid. So what it will do to your immune system? It's going to cause immunosuppression. It's going to cause immunosuppression. Cortisol, what it will do to your blood cells? What it will do to your blood cells? Say it increases your RBC, it increases your platelets, it decreases your WBCs, it decreases all the WBCs except neutrophils. Except neutrophils and monocytes. Monocytes is not important, at least neutrophils is important. Okay, so cortisol is going to increase your neutrophils. So cortisol is going to cause a neutrophilia. True. Cortisol is a stress hormone. During stress, do you want any reproductive activity? No, right? So cortisol is going to inhibit GnRH, FSH and LH. Okay, so cortisol is going to inhibit the reproductive axis. So the same cortisol, it increases your acid production. Acid production is going to be increased. Cortisol is going to activate osteoclasts. So they causes bone resorption. So they increases the bone resorption. Bone resorption means what? Bone breakdown. They are going to cause a bone breakdown. Okay. So these are some important points about the cortisol. It's a stress hormone. Okay. It increases the blood glucose levels. It causes the proteolysis, lipolysis, immunosuppression. It causes the neutrophilia. It inhibits the reproductive axis. It inhibits the it activates the osteoclast, causes the bone resorption. It's going to increase the acid levels. Okay, that can lead to peptic ulcer disease later. Increase in the cortisol. Okay, increase in the cortisol is going to cause which syndrome? Cushing syndrome. Cushing syndrome. Increase in the cortisol is going to cause which syndrome? Cushing syndrome. Now, tell me, what is the most common cause of Cushing syndrome? If they ask you in your exam, what is the most common cause? Is iatrogenic. Iatrogenic means doctors unnecessarily prescribing steroids. Okay, steroids, if the patient is taking steroid continuously, steroids are glucocorticoids. So that can lead to Cushing syndrome. What else you should know? See, thyroid hormone, let's say something like this. All steroid hormones like testosterone, testosterone, estrogen, cortisol, aldosterone, all steroids have intracellular receptors. They cross the cell membrane. They cross the cell membrane. They do not have cell surface receptor. They have the intracellular receptor. The receptor is present within the cell. Okay. One important recent PYQ is thyroid hormones. Thyroid hormones, yes, they do have intracellular receptor. They are also having receptor within the cell, but where? They have intranuclear receptors. It's a PYQ. So thyroid hormones, yes, they have intracellular receptors. All steroids, they have intracellular receptors, but thyroid hormones specifically, they have intranuclear receptor. Remember that point. What else you should know? See, there is oxytocin and antidiuretic hormone, oxytocin and antidiuretic hormone. From where they are produced? They are produced in hypothalamus only, not posterior pituitary. They are produced in hypothalamus. Which nucleus of the hypothalamus is going to produce oxytocin? Recent question, supraoptic nucleus. The supraoptic nucleus of hypothalamus, is going to produce oxytocin, which is going to cause the uterine contraction and helps in the delivery of the baby. But oxytocin is going to cause the milk ejection also. That's okay. Then who produces the, sorry, it's my mistake. Oxytocin is produced by the paraventricular nucleus, not the supraoptic nucleus, paraventricular nucleus. It's the supraoptic nucleus produces the antidiuretic hormone. So supraoptic nucleus, SON, supraoptic nucleus produces the antidiuretic hormone and paraventricular nucleus is going to produce the oxytocin. Okay, so two important nucleus, hypothalamic nucleus and their hormones. Okay, with this the important points which you should know regarding the endocrine physiology are completed. Now let me discuss a few important topics which you should know from the GIT physiology. From the GIT, okay, the most important things. What are they for your FMG exam? So in GIT physiology, what you should know, guys, in your stomach, okay, in your stomach, there are different cells present. Okay, there are different cells present. For example, look, in your stomach, there are gastric glands. For example, a gastric gland is going to look like this. These gastric glands are made up of different types of cells. Okay, each cell produces a different type of secretion. For example, first type of cell, let's say, which is there on the surface, so that is called as a surface mucus cell. Surface mucus cell. The surface mucus cell of the gastric gland is going to produce what? Mucus, not a big deal. But the surface mucus cell is also called as foveolar cell. So foveolar cells are present where? Foveolar cells are present in the stomach. They produce what? Mucus. Next, in the stomach there is parietal cell present. Parietal cell is going to produce what? Parietal cells are going to produce HCl, acid and intrinsic factor. Now this intrinsic factor is helping in the absorption of vitamin B12. Where is this vitamin B12 going to be absorbed? Vitamin B12 is going to be absorbed in ileum. Okay. Next cell is enterochromaffin-like cell. Okay, ECL cell, enterochromaffin-like cell. This enterochromaffin-like cell is going to produce histamine. The histamine will act on the parietal cell, helps in the production of acid. It helps in the production of acid. Next cell, G cell. G cells produce gastrin. Gastrin also acts on parietal cell so that it helps in the production of acid. So tell me, there are how many stimulus for the release of acid? See, histamine is a stimulus for the release of acid. Gastrin is a stimulus for the release of acid, but acid is produced by which cell? Parietal cell. Acid is produced by the parietal cell. Okay. Next, D cell. D cell produce somatostatin. What is the somatostatin going to do? Decreases the acid, decreases the HCl. Okay. Next, chief cell. Chief cell produce pepsinogen and gastric lipase. Okay, so pepsinogen and gastric lipase. Pepsinogen is a digestive enzyme. It's going to digest the proteins. Pepsinogen will be converted into pepsin. So pepsinogen will be converted into pepsin. It helps in protein digestion. Okay, helps in protein digestion. gastric lipase is going to digest lipids. Okay. Question is the pepsinogen to pepsin conversion. Who is going to convert the pepsinogen to pepsin? Acid. The acid in the stomach is going to convert the pepsinogen to pepsin. So tell me, these are the different types of cells and their secretions. Different types of cells and their secretions. Okay. Now it's very clear here. It's very clear that in the stomach there is an enzyme for the protein digestion and there is even an enzyme for the lipid digestion. But who is not getting digested? Carbohydrates. So amylases are not produced in the stomach. So no amylases in stomach. No carbohydrate digestion in the stomach. Okay. Next, what you should know is the phases of gastric acid production. How many? Sorry, let me tell you something important. This is the parietal cell. Let's say this is the parietal cell. This parietal cell is producing the acid. You know it, HCl. So what are the stimuluses I have told you for the release of acid? Two stimulus I have told you already. That is histamine and gastrin. Apart from histamine and gastrin, there is also one more stimulus for the release of acid. That is acetylcholine. So in total there are three stimulus. One is acetylcholine, gastrin and histamine. All of them, they will act on the parietal cell to produce acid. Okay. Next, in how many phases the acid will be produced? In how many phases? In three phases. One is cephalic phase. What exactly is cephalic phase? The moment you think about the food in your brain, the moment you think, almost acid is produced. Almost how much percent? 30% acid is produced. 30% acid is produced because of the activation of the parasympathetic nervous system. The vagal activation is going to trigger the release of acid. So this is called as the cephalic phase of acid production, 30%. The next phase is called as gastric phase. In gastric phase means when you actually eat the food, when you actually put the food into your stomach, how much acid will be produced? 60% acid will be produced. That is gastric phase of acid production. Next, intestinal phase. In intestinal phase means the food is going into the intestines, then the acid production drops to 10%. So these are the three phases of gastric acid production. The question which was asked in the exam is, in which phase maximum gastric acid is produced? That's the gastric phase. How much? 60%. 60%. Okay. Next, who inhibits gastric emptying and who promotes gastric emptying? That's the question. Look here, guys. Let's say this is your stomach and here is your duodenum. Okay, here is the duodenum. Now what is the sphincter that is present over here? This is the pyloric sphincter. Okay. Now let's talk about the food. Okay. There are different types of food, right? Carbohydrate, proteins, fats. If you talk about the carbohydrates, okay, they will stay in your stomach for a very little time. They will stay in stomach for a little time, like somewhere around 3 to 4 hours. Okay, 3 to 4 hours. Within 4 hours, the food will enter into the duodenum. The carbohydrate food will have a fast gastric emptying. Okay. So which foods are going to have the fast gastric emptying? Carbohydrates are going to have the fast gastric emptying, followed by proteins. Means proteins are going to stay in your stomach somewhere around 6 to 7 hours. And fats. Fats will stay in your stomach for long time, 9 to 12 hours. Okay. So which foods are having fast gastric emptying? It's a carbohydrate followed by protein followed by fats. This is the order of gastric emptying. Next, see, let's talk about the hormones. Which hormones are going to promote the gastric emptying? Who promotes the gastric emptying? Means the movement of the food from the stomach into the intestines. Who will stimulate the movement of food from the stomach into the intestine? Who promote the gastric emptying? The answer is gastrin. So gastrin promotes, that's why I use the word positive, promotes the gastric emptying. Okay. Then who inhibits the gastric emptying? Gastric emptying is inhibited by which hormones? One is secretin, cholecystokinin, secretin, amylin. They all inhibit the gastric emptying. They slow down the process of gastric emptying. So food is moving slowly. Okay, so who inhibit the gastric emptying? Secretin, cholecystokinin and amylin. Question is, who produces this secretin? Secretin is produced by S cells on duodenum. S cells on duodenum. Cholecystokinin is produced by I cells on duodenum. Amylin is produced by beta cells of pancreas. Okay. Some important points about the secretin. Secretin का function क्या है body में? What is the function of secretin? Secretin is called as nature's antacid. Okay, secretin is called as which hormone? Nature's antacid. What it will do? It increases the bicarbonate levels. Okay, it increases the bicarbonate production. It increases the bicarbonate levels in pancreatic juices. Okay, again is the acid. Okay, it neutralizes the acid. So secretin, when it acts on the pancreas, it makes the pancreatic juices more alkaline. Bicarbonate rich pancreatic juices. Okay, that's the function of secretin. Next, what is the function of I cells? I cells have two functions. I cells produce cholecystokinin, you know it. Cholecystokinin have two functions. Cholecystokinin, the name itself is there. Cholecystokinin. Cholecysto, it's going to contract. What is a cholecyst? Gallbladder. So it contracts gallbladder. Contract gallbladder. It causes the gallbladder contraction. So can I call it as a cholegog? Yes. So cholecystokinin, it causes the gallbladder contraction and helps in the bile release. So it is called as cholegog. Okay. And not only that, the cholecystokinin, when it acts on pancreas, pancreatic juices will become rich in enzymes. So cholecystokinin, it makes pancreatic juices rich in enzymes. Okay, it makes the pancreatic juices rich in enzymes. So these are important points about cholecystokinin, secretin. Okay, they both inhibit the gastric emptying. Now let me tell you some important points about pancreas. Okay, some important points about the pancreatic enzymes. See, pancreas is going to produce, okay, enzymes for carbohydrate digestion. So pancreas will produce pancreatic amylase, which will help in carbohydrate digestion. Pancreas will produce enzyme for the lipid digestion. So lipases. So which lipases? Pancreatic lipase, colipase. Okay, pancreatic lipase and colipase. See, this is the question which was asked in the exam. Colipase is produced by pancreas, present in pancreatic juices. Not only that, pancreas will also produce proteases for the protein digestion. What are they? Trypsinogen, trypsinogen and procarboxy peptidase. Okay, procarboxypeptidase. So pancreas is producing trypsinogen, chemotrypsinogen and procarboxypeptidase. In the duodenum, the trypsinogen will be converted into trypsin with the help of an enzyme called as enterokinase or enteropeptidase. Is going to convert the trypsinogen to trypsin. Chemotrypsinogen will be converted into chemotrypsin. Chemotrypsinogen will be converted into chemotrypsin with the help of enzyme trypsin. Okay, then so pancreas is going to digest everything. Pancreas is going to digest carbohydrates, proteins, fats. In stomach there is no carbohydrate digestion. But what about the mouth? In mouth, what is getting released? In mouth there is secretion of saliva, right? So let me write that also here. Note, in mouth there is no protein digestion. Okay, there is no protein digestion. In your mouth, what is there? Saliva is there. In saliva, there is something called as thylline, also called as salivary amylase. Okay, thylline or salivary amylase. It's going to help in the digestion of carbohydrates. Okay, for the carbohydrate digestion. Okay, for the carbohydrate digestion, there is thylline or salivary amylase there in the saliva. Not only that, there is lingual lipase. Lingual lipase, you know it, it's there for the digestion of lipids. Lipase for the digestion of lipids. So in mouth, there is no digestion for the proteins. In stomach, there is no digestion for the carbohydrates. Okay. After this, what else I will ask you is different sites and their absorptions. Okay. For example, let's say iron. First, different substances and their absorption. Iron. Where is iron absorbed? Iron is mainly absorbed in duodenum. Vitamin B9 is mainly absorbed in jejunum. Vitamin B12 is mainly absorbed in ileum. Right? Regarding the iron, they will ask you which form of iron is absorbed in the duodenum. Only ferrous. Only ferrous form of iron is absorbed. Okay, only a ferrous form of Fe2 plus form of iron is absorbed. Okay, in the duodenum. With the help of which transporter? DMT1. There is a transporter called as a DMT1. In your intestines, in your enterocytes, there is a DMT1 which helps in absorption of iron. DMT1. Okay. Which form of iron is absorbed? Fe2 plus. But what about Fe3 plus form of iron? It's a not absorbable form of iron. The Fe3 plus form of iron need to be converted into Fe2 plus form of iron. Who will convert that? HCl, acid, and vitamin C, ascorbic acid. So it's the acid and ascorbic acid. Acid, HCl and ascorbic acid converts Fe3 plus form of iron to Fe2 plus form of iron. So these substances, okay, acid and vitamin C, they increase iron absorption. Okay, they increase the iron absorption. Then who will decrease the iron absorption? It's a recent question which was asked. Who will decrease the iron absorption? It is milk, phytates, tannins, which is present in the tea, okay, and antacids. They are all going to decrease the iron absorption. Milk, phytates, tannates, tea, like no, antacids, they are all going to decrease the iron absorption. Okay, the important sites and their absorptions. Who will decrease the iron absorption into the body? Who will inhibit the iron absorption into the body? There is something called as hepcidin. Okay, hepcidin, it is produced from the liver. Liver produces hepcidin, and what this hepcidin will do is going to decrease the iron absorption. Hepcidin also decreases the iron absorption. Okay, how? Hepcidin inhibits a transporter called as ferroportin. Okay, there is an iron transporter called as a ferroportin. That ferroportin is needed for the absorption of iron into the blood. So this hepcidin will inhibit the ferroportin, so that iron is not going to come into the blood. Hepcidin inhibits the iron absorption. Okay, so anything left in the GIT? Yes, one more thing is there. One more important thing is there. I forgot to mention. That's the GIT contractions. GIT contractions. When you are in fed state, okay, when you are in fed state, that means you have taken food. Now there is food in your intestines, the stomach. Now when the food is there inside your stomach, now your GIT is going to contract or not? Yes, your GIT is going to contract. First type of contraction is called as peristalsis. So what exactly is peristalsis? In peristalsis, look here. See, let's say this is your intestine. Okay. Now, this proximal segment, the first part is contracting. The proximal segment is contracting to prevent the regurgitation of the food, backflow of the food. And the distal segment is going to relax. Here is a foot bolus. Let's say here is a foot bolus. is food. The proximal segment is contracting and the distal segment is relaxing, so that the food is going only in oral direction, away from the mouth, in one direction towards the anus. Okay, the food is moving. So this is called as a peristalsis. I have told you the proximal segment is contracting, right? The proximal segment is contracting. What are the neurotransmitters? What are the neurotransmitters which are helping in the contraction? Which neurotransmitters? That is acetylcholine and substance P. So acetylcholine and substance P are causing the contraction of the proximal segment. And which neurotransmitters are causing the relaxation? Relaxation is done with the help of nitric oxide and vasoactive intestinal peptide. Okay, so nitric oxide and vasoactive intestinal peptide is going to cause the relaxation. Contraction is done with the help of acetylcholine and substance P. So this is called as peristalsis. Then what is segmentation? One more type of GIT contraction, that is called as a segmentation. In segmentation, see, the proximal segment is contracting and the distal segment is also contracting. Actually, the food is now just divided into small pockets. The food is moving forward and backward. Okay, forward and backward. So that the food is getting mixed. The food is getting mixed with what? The food is getting properly mixed with the digestive enzymes. Okay, the food is mixing with the digestive enzymes. So segmentation is not a propulsion movement. Peristalsis is for propulsion. Segmentation is a mixing movement. It's going to mix the food with the enzymes, so that food will be, at the end of the day, food will be digested. So segmentation is for mixing and digestion. Okay, peristalsis is for the propulsion, P for P. Peristalsis is for the propulsion. Segmentation is mixing and digestion. In peristalsis, you have to see only one forward arrow, that's it. The food is moving forward. Proximal segment contracted, distal segment relaxed. Okay. Now, even during fasting state, when you are fasting, you haven't eaten anything, you are doing fasting. Even during fasting state, your GIT is going to contract, even without food. That contraction is called as migratory motor complex. This migratory motor complex is mediated, MMC, migratory motor complex is mediated with the help of a hormone called as motilin. So motilin is going to mediate migratory motor complex. Okay, so these are the points which I want you to know. One more important point regarding motilin. Motilin is, see, let's say this is your intestine. Let's say this is your intestine. Okay, here is the smooth muscle. Here is a smooth muscle. Let's say here are the smooth muscles. Your intestines are covered by the smooth muscles. Okay, here is a smooth muscle. Here is a motilin receptor. This is a motilin receptor. It's motilin receptor. Who is going to stimulate this motilin receptor? Motilin will come and it stimulate the motilin receptor, so that you are having migratory motor complex. GIT is going to contract. Okay, that's good. But there is a drug. There is a drug which will come and stimulate this motilin receptor. Do you know what is a drug? There is a drug which will stimulate the motilin receptors, causing the GIT, unnecessary GIT contractions. That is called as erythromycin. Erythromycin. So erythromycin is going to stimulate the motilin receptors. So that's going to cause the GIT contractions. So this erythromycin, it is used in the treatment of, okay, it is used in the treatment of diabetic gastric paralysis. Diabetic gastric paralysis or paralytic ileus. Okay, paralytic ileus. So these are the conditions where you can use this antibiotic called as erythromycin. It's going to stimulate the motilin receptors. So with this, the important points in the GIT are completed. So what is the last chapter that is left over? The last chapter that is left over is the central nervous system. So even without any further late, let's see the important topics which you should know in the central nervous system. Central nervous system. In the central nervous system physiology, what they will ask you is, this is an important area. Look, let's say this is your brain. Okay, this is your brain. Here there is a central sulcus present. There is a central sulcus. Now back to the central sulcus, there is an area called as a post-central gyrus. This is post-central gyrus. Area number, Brodmann's area number 3, 1, 2. It is your sensory cortex. This is your sensory cortex, somatosensory cortex. You are feeling everything over there. Okay. So this pre-central gyrus, this area which I am highlighting in the blue color, this is called as the pre-central gyrus, the pre-central gyrus. This pre-central gyrus is your motor cortex, Brodmann's area number 4 and 6, that's a motor cortex. Okay, it's going to help you in your movements, motor cortex. Not only that, in the recent exam, the question which was asked is, there is a inferior frontal gyrus. Inferior frontal gyrus, here in this inferior frontal gyrus, there is an area. Okay, in this inferior frontal gyrus, there is an area. Okay, which is helping in the speech purpose. Okay, in the inferior frontal gyrus, there is an area which is helping in the purpose of speech. What is this area called as? That is called as a Broca's area. It's a motor speech area. The motor speech area. Brodmann's area number 44. Okay, it's a motor speech area. Where it is located? In the inferior frontal gyrus. Okay, it's a motor speech area. In the superior temporal gyrus, there is one more area here which I am showing you. This is called as a superior temporal gyrus. Okay, in the superior temporal gyrus, there is one more area that is called as Wernicke's. Wernicke's area. This Wernicke's area is for understanding. Okay, it's for understanding. I am talking, you are understanding what I am speaking, right? So it's for comprehension. It's for the comprehension. What is the Brodmann's area number? 22. Brodmann's area numbers 22, 44, 22. Okay, so Wernicke's area is located in the inferior frontal gyrus, and this Wernicke's area is located in the superior temporal gyrus. Okay, superior temporal gyrus. If Broca's area is damaged, for example, say they say there is a vascular injury to the inferior frontal gyrus. If the vascular lesion is there to the inferior frontal gyrus, the Broca's area is going to be affected. If the Broca's area is affected, like the person is not going to speak properly. So there is broken speech. Okay, the patient is going to have expressive aphasia, means he can't express properly. So the patient is going to have broken speech. Expressive aphasia. If the Wernicke's area is damaged, he can't understand. The comprehension will be affected. So the person is speaking but doesn't make any sense. He's speaking but he's not understanding properly, and he's speaking something like blah blah blah. Doesn't make any sense. This is called as a fluent aphasia. Okay, so Broca's aphasia is an expressive aphasia. Wernicke's aphasia is a fluent aphasia. Fluent aphasia. These are the important areas. Okay. Now, let's see some important things which you should know regarding the central nervous system physiology. Ascending tracts. In a simple way, there are two types of ascending tracts. What are the two types of ascending tracts? One is ascending tracts are sensory. They will take the information towards the brain, right? Ascending tracts. One is antero, lateral, anterolateral, sino, thalamic tract, anterolateral spinothalamic tracts, and dorsal column tracts. Okay, anterolateral spinothalamic tracts and dorsal column tracts. These are the two types of ascending tracts which are present in humans. Now, this anterolateral spinothalamic tracts, they carry which sensations towards the brain? They carry which type of sensations to the brain? Okay, they carry primitive sensations. They carry primitive sensations. Which primitive sensations? Touch, pain, temperature, and pressure. Touch, pain, temperature, and pressure. These primitive sensations are carried by anterolateral spinothalamic tract. Anterolateral spinothalamic. Okay, that too, listen carefully, listen carefully. Here the anterolateral spinothalamic tract is actually divided into two types, anterior spinothalamic tract and lateral spinothalamic tract. This pain and temperature are carried by lateral spinothalamic tract. Lateral spinothalamic tract carry pain and temperature. And this anterior spinothalamic tract, it is going to carry which information? Touch and pressure. Touch and pressure. Okay, so tell me, pain and temperature are carried through the lateral spinothalamic tract, and touch and pressure are carried by the anterior spinothalamic tract. Okay. Now they will ask you simply, lateral spinothalamic tract damage to the lateral spinothalamic tract, loss of temperature and pain. Damage to anterior spinothalamic tract, loss of touch and pressure. Okay. Now these anterolateral spinothalamic tracts which are carrying the primitive sensations, they will cross within the spinal cord. Okay, they will cross within the spinal cord. Left-sided sensations will cross to the right side, right-sided sensations will cross to the left side. So anterolateral spinothalamic tract, they are crossed tracts. Okay, they are crossed tracts. True. The dorsal column tracts. Now let's discuss about the dorsal column tracts. Dorsal column tracts, they are advanced tracts. They are highly myelinated. Okay, they are highly myelinated. They carry advanced sensations. They carry advanced sensations. So what are those advanced sensations which are carried by the dorsal column tracts? The advanced sensations, they include fine touch, not good touch, fine touch, vibration, 2-point discrimination, stereognosis, proprioception. So these are all the advanced sensations. Here I have written, these are the advanced sensations like fine touch, vibration, 2-point discrimination, stereognosis, and proprioception. These are the advanced sensations going through the dorsal column of the spinal cord. They are going through the dorsal column tracts. If there is a damage to the dorsal column of the spinal cord, you are going to lose these advanced sensations. If you are having any damage to the anterior side or the lateral side of the spinal cord, the patient is going to lose this primitive sensation. And the thing is that is the dorsal column tracts, they do not cross at the level of spinal cord, they will cross at the level of medulla. Okay, they will cross. Dorsal column tract crosses at the level of lower medulla. They do not cross in spinal cord. In the spinal cord, they are not crossed. They are traveling on the same side. Dorsal column tracts do not cross. They are traveling on the same. Okay. Now, look at here. Let's say here is a spinal cord. Okay. Here, what is this tract which I am showing here? This is the dorsal column tract. It's there on the dorsal side, back of the spinal cord, dorsal column tract. Here is the, let's say this is the lateral spinothalamic tract, lateral spinothalamic, and here is the anterior spinothalamic. Now, let's say in this person, half of the spinal cord is damaged. Okay, half of the spinal cord is damaged, half of the spinal cord damaged. So this is hemisection of spinal cord. Hemisection of spinal cord means half of the spinal cord is gone. So tell me which tracts are affected? Yes, dorsal column tracts are affected. Not only that, this anterolateral tracts are also affected. So this condition is called as Brown-Séquard syndrome. Okay, Brown-Séquard syndrome. So in Brown-Séquard syndrome, there is hemisection of the spinal cord. Which sensations are going to be lost? So dorsal column sensations, advanced sensations lost on same side of the body. Advanced sensations are lost on the same side. Ipsilateral loss of the advanced sensations, because I have told you dorsal column sensations will not cross in the spinal cord. And primitive sensations loss on opposite side. Because you know these primitive tracts, the anterolateral tracts, they will cross within the spinal cord itself. They will cross within the spinal cord. So this tract is carrying the sensations from the opposite side of the body. So the patient is going to lose the primitive sensations on the opposite side, advanced sensations on the same side. So this is Brown-Séquard syndrome. Okay, Brown-Séquard syndrome. Now, let me discuss about the descending tracts also here itself. In the descending tracts, again there are two types: pyramidal, also called as corticospinal, extrapyramidal. Extrapyramidal tracts. Okay, so these corticospinal tracts are of two types. Cortex, so they are coming from the cortex to the spinal cord. Corticospinal tracts are of two types: lateral corticospinal, anterior corticospinal. Okay, anterior corticospinal, lateral corticospinal. And extrapyramidal tracts are different. Extrapyramidal tracts include reticulospinal, tectospinal, vestibulospinal, rubrospinal. These are all the extrapyramidal tracts. See, the function of this descending tract, at the end of the day, the function of the descending tracts is to control the motor movements. So all this lateral corticospinal, anterior corticospinal, even this extrapyramidal tracts, they are trying to control the motor movements in the body. Okay. Now, what else you should know in the central nervous system? Important areas that you should know in the central nervous system is basal ganglia. Basal ganglia. See, the basal ganglia, the function of the basal ganglia is important. What is the function of the basal ganglia? Basal ganglia plans motor movements. Basal ganglia, it plans the motor movements. It stores the motor movements. It plans the motor movements. Okay, how to perform swimming? There should be a program, right? Which muscle to contract, how much to contract, how to walk, how to do somersaulting, how to ride a bicycle, how to typing. All these motor programs are stored in a structure called as the basal ganglia. Actually, basal ganglia is not a one single structure. It's made up of different nuclei. Okay, so basal ganglia plans the motor movements, and also it inhibits. Okay, it inhibits involuntary movements. It plans the motor movements and it inhibits the unnecessary movements. Okay, so what are the structures involved in the basal ganglia? What are the different structures present in the basal ganglia? There are 5 different structures. One is caudate nucleus, Next, putamen. Okay, caudate nucleus. Putamen is there. Globus pallidus. Substantia nigra. Subthalamic nucleus. Okay, subthalamic nucleus. So, caudate nucleus and putamen together called as striatum. Okay, caudate nucleus and putamen together it's called as what? Striatum. So, these are the 5 different structures which are present in the basal ganglia. Now, in between these structures, there is a circuit that is present. There is a circuit which is present within this within these structures. That is called as a direct pathway. And indirect pathway. Okay, direct pathway and indirect pathway. Okay, in between these 5 different structures, there is a circuit that is present. That is called as a direct pathway, indirect pathway. In direct pathway, what exactly happens is, in direct pathway, in the circuit, ultimately the motor cortex is activated. The motor cortex will be activated so that it stimulates the direct pathway is going to help in movements, facilitation of movements. Facilitation of movement. In indirect pathway, what exactly happens is it inhibits movements. Inhibits movements. It's very clear, right? Whenever we want movement, there should be a movement, and whenever we don't want movement, it should be inhibited. So this is both direct and indirect pathways, both are working simultaneously. What they are doing, they are stimulating wherever there is a movement required, that movement will be initiated, and wherever you don't want movement, that should be inhibited. Okay, so both this direct pathway and indirect pathway, they are helping in the coordination. Okay, now this direct pathway is actually activated with the help of dopamine. So dopamine will stimulate the direct pathway and dopamine will inhibit the direct pathway. Okay, dopamine stimulates the direct pathway and inhibits the indirect pathway. So finally, what dopamine will do is dopamine will facilitate movements. Dopamine facilitates the movements. Always dopamine is facilitating the movements. Okay. Now, what they will ask in your exam, they will ask you what are the components of basal ganglia. One question. What is the function of basal ganglia? Plans the motor movements, and it plans and stores the movements, motor movements. It inhibits the involuntary movements. Direct pathway, indirect pathway, they will ask you. In direct pathway, motor cortex is activated. In indirect pathway, motor cortex is inhibited. Dopamine will stimulate the direct pathway. Now, look here. If there is a lesion of basal ganglia, a lesion to the basal ganglia means basal ganglia is damaged, some structure of the basal ganglia is damaged. If the basal ganglia is damaged, you tell me, if the structures related to the basal ganglia is damaged, there will be unnecessary movements, involuntary movements that's going to be there. For example, caudate nucleus damage. So damage to caudate nucleus is going to cause abnormal movements called as chorea. Okay, damage. So chorea. Next, damage to subthalamic nucleus. Damage to subthalamic nucleus is going to cause a type of involuntary movement called as hemibalismus. Damage to globus pallidus is going to cause a type of involuntary movement called as athetosis. Athetosis. Okay, athetosis, instead of writing the word athetosis, they will say writhing movements. Writhing, not writing, writhing movements. Instead of saying chorea directly, they will say they are like flicking movements. Flicking movements. Instead of hemibalismus, they will say flinging movements. Okay. Flinging movements are railing movements. Okay. So, damage to the basal ganglia, different structures, caudate nucleus damage, or they will say striatal damage. Because caudate is a part of striatum, is going to cause the chorea, subthalamic nucleus damage is going to cause the hemibalismus, and globus pallidus damage is going to cause the athetosis, writhing movements. So, these are the important things which you should know regarding the basal ganglia. Next, ECG. Sorry, EEG. EEG. Based on the activity of your brain, you will get different waves. Okay, so the frequency of the waves is directly proportional to brain activity. Okay, the frequency of the waves is directly proportional to the brain activity. For example, let's say the person just woke up, he haven't even opened the eyes, he's not thinking about anything, he's almost in a meditative state. Okay, he's almost in a meditative state. He's completely relaxed. So, relaxed, not sleeping, he's not sleeping. Okay, he's not sleeping. Eyes closed. Which waves are going to come? Alpha waves. Alpha waves are going to come. Okay, when a person is not sleeping, he's absolutely relaxed, he's in a meditative state, his eyes are closed. Which waves are going to be dominant? Alpha waves. What is the frequency of alpha waves? 8 to 12 hertz. 8 to 12 hertz. The frequency, the number of waves that are coming in a second. The frequency. When the person is actively thinking, busy mind or active mind, then beta waves are going to come. Beta wave frequency is 13 to 30 hertz. 13 to 30 hertz. When a person is having intense mental activity, intense focus, the frequency is going to be more than 60 hertz. Those waves are called as gamma waves. Okay, gamma waves, intense mental activity, gamma waves. Okay, alpha wave completed, beta wave completed, gamma wave completed. Now, when the person is going to into light sleep, drowsiness, then you are going to have theta waves. The frequency of the theta waves is going to be 4 to 7 hertz. 4 to 7. Next, deep sleep. The person is going into deep sleep. In deep sleep, the person is going to have delta waves. Frequency of delta waves is 1 to 3 hertz. Deep sleep or dreaming. Okay, deep sleep or dreaming, the patient is going to have delta waves. Delta waves are also called as slow waves. Okay, theta waves are also called as memory waves. Okay, alpha wave is also called as Burger waves. Beta wave is also called as EEG desynchronization wave. Okay, now in sleep, let me say important some points about the sleep. Sleep is mainly divided into two phases. One is NREM, that is non-rapid eye movement, and REM, rapid eye movement sleep. Okay, NREM and REM. In NREM, there are further stages. NREM stage 1, 2, 3, 4. NREM stage 1, 2, 3, 4. In NREM stage 1, see NREM, the sleep begins with NREM stage 1. Okay, sleep is going to begin with the NREM stage 1. So, NREM stage 1, what do you think? It's going to be light sleep or deep sleep? It's going to be light sleep. So, which waves are going to be seen in light sleep? Theta waves. EEG waves. Which waves? Theta waves are going to be seen. In stage 2 NREM, okay, we spend most of the time we spend in NREM stage 2. Okay, most of the sleep is NREM stage 2. If you check the frequency of the brain, the frequency of the waves that is coming is 8 to 12 hertz. Okay, 8 to 12 hertz. Now, are they alpha waves? 8 to 12 hertz is coming. Are they alpha waves? No, they are not alpha waves. Here, because the person is sleeping, the person is not active, the person is sleeping. Okay, here, especially in NREM stage 2, okay, you will see sleep spindles and K complexes. That is important. Sleep spindles, K complexes in the EEG. NREM stage 3 and stage 4, they are deep sleep. As they are deep sleep, which waves are going to be seen? Delta waves. The frequency is going to be 1 to 3 hertz. Done. In REM sleep, if you check the electrical activity of the brain, in REM sleep, the frequency of the waves that are coming is going to be 13 to 30 hertz. Are they beta waves? Yes, they are beta waves. They are beta waves. They are beta waves. That's why actually beta waves are supposed to be seen during busy mind, but the beta waves are coming during REM sleep. So that's why REM sleep is called as a paradoxical sleep. Okay, that's why REM sleep is called as what? Paradoxical sleep. Okay. In REM sleep, what else you will be seen? In the EEG, there will be PGO spikes, pontogeniclo-occipital spikes. PGO spikes will be the same. PGO spikes will be the same. Okay, so these are the important differences between REM sleep and NREM sleep. NREM sleep, there are phases 1, 2, 3, 4. Especially in NREM phase 2. Look, in NREM phase 2, certain sleep abnormalities can be seen. Okay, sleep abnormalities can be seen. For example, let's say in NREM stage 2, bruxism. Bruxism is the teeth grinding. Teeth grinding. It is in NREM stage. Stage 4, especially in the deep sleep, there will be somnambulism. Sleepwalking, somnambulism, sleepwalking, somnambulism, bruxism. These are all the parasomnias which will be seen during NREM. Okay, now if I am talking about the dreams, very important. You tell me, dreams will occur during NREM or REM? Dreams occurs both during NREM and REM. Dreams occur both during NREM and REM. But whatever the dreams that occur during NREM, they are not remembered. They are called as night terrors. And what are the dreams that will occur during REM? REM dreams can be remembered. They are called as nightmares. Okay, nightmares are the bad dreams which can be remembered during REM, and night terrors are the bad dreams which cannot be remembered. So dreams occurs during both REM as well as REM. Okay, so these are some important points about the sleep. Now if I say some important points about the different nuclei of the hypothalamus, if I am talking about the hypothalamic nuclei, so hypothalamic nuclei. Okay, there are very important functions of the hypothalamus. In a recent exam, this question has been asked. Hypothalamus is a thermoregulatory center. It's a thermoregulatory center, means it maintains your body temperature. Hypothalamus is the thermoregulatory center. It maintains your body temperature. Which nucleus is going to increase your body temperature? Which nucleus is responsible for decreasing the body temperature? It's the anterior nucleus. Anterior nucleus, A for AC. Anterior nucleus is going to cool down your body. It's going to cool down your body with the help of shivering. Okay, sweating. It's going to cool down your body with the help of sweating. And posterior nucleus is going to warm your body by shivering. It warms the body. Okay, the two nucleus, anterior nucleus and posterior nucleus. Anterior nucleus is going to cool down your body, posterior nucleus is going to warm your body. Okay, next, there is something called as suprachiasmatic nucleus. Suprachiasmatic nucleus. Suprachiasmatic nucleus is going to regulate your sleep-wake cycles. It's going to regulate your sleep-wake cycles. Also, we can call it as, like, we can say circadian rhythm. The 24-hour activity is again and happening again and again. So circadian. Okay, the circadian rhythm. So who is going to control your circadian rhythm or a biological clock? It's a suprachiasmatic nucleus. Suprachiasmatic nucleus. One more nucleus. That's a ventromedial nucleus. Ventromedial nucleus. The ventromedial nucleus of hypothalamus is the one which is going to make you feel satiety. Okay, the ventromedial nucleus is your satiety center. Okay, lateral nucleus of hypothalamus is your hunger center. Okay, so hunger center, the one which is making you feel hungry, is your lateral nucleus, and the one which is making you feel full is the ventromedial nucleus. So these are the different nuclei. Okay, you anyway know there is a suprachiasmatic nucleus which is helping the production of antidiuretic hormone, and paraventricular nucleus is helping the production of oxytocin. Already I have discussed this in the endocrine. Now look here, posterior hypothalamus or the posterior hypothalamic nuclei okay, posterior hypothalamic nuclei is also posterior as well as lateral. Is keeping you awake. Okay, these nuclei will keep you awake. So right now, those who are listening to this class, you are awake, right? Which nucleus is helping you to keep awake? There are many nucleus, but which hypothalamic nucleus is keeping you to awake? It's the lateral hypothalamic nuclei and posterior hypothalamic nuclei. Same, these nuclei only. In the beginning also I have told you, see this posterior hypothalamic nuclei and this lateral nuclei. Yeah, they do have a role in other things, but they also have a role to keep you awake. Okay, these are different hypothalamic nuclei and their functions. Now, in one of the FMGe exam, they have asked a nucleus of thalamus, not the hypothalamus. See, thalamus is mainly sensory in function. It's mainly sensory in function. All the sensations will come to the thalamus. Every sensation will come to the thalamus except the olfaction. Except olfaction, all the sensations will come to the thalamus. So that's why thalamus is called as a relay center. Okay, it's called as a relay center. Which nucleus receive all the information? All the sensations are coming to which nucleus of the thalamus? It's a ventroposterolateral. There is a nucleus called as a VPL. Ventroposterolateral receives all sensation. Okay, receives all the sensation. There is a nucleus called as a ventroposteromedial nucleus. The ventroposteromedial nucleus is receiving taste sensation. It's going to receive the taste sensation. Okay. In the same way, they will ask you regarding the thalamus only. There is something called as lateral geniculate nucleus of the thalamus. Lateral geniculate nucleus. This lateral geniculate nucleus is going to receive information about the vision. The light information will go to the lateral geniculate nucleus. The medial geniculate body or the medial geniculate nucleus is going to receive the information about the hearing. Okay, medial geniculate body or the medial geniculate nucleus. So these are the different nuclei of the thalamus. Okay, so this is a question. Ventroposterolateral nucleus is receiving all the sensation. Okay, taste is coming to the ventroposteromedial. In your brain, there is something called as a reward center. So what is that reward center? Reward center where the dopamine is going to be released, or like the person is getting addicted. Okay, that is nucleus or addiction center, you can say. Nucleus accumbens. Okay, so nucleus accumbens is the addiction center. Okay, addiction neurotransmitter is dopamine. It gives you pleasure, which will lead to addiction. So with this, the important points, all the important points in your central nervous system is completed. So all the systems, I have completed all the systems, mainly the important topics, the main important topics are done. Last time I have made a rapid revision video, mainly I have concentrated there on the PYQs, previous year questions. Okay, if you have time, I highly recommend you to watch that video also, because there all the previous year questions are also covered. Okay, here I have covered all the systems with all the MCQ points. Okay, recently 1 month back in our SARS channel, okay, I have done the same rapid revision for the general physiology. Okay, in 1.5 hours I have done the rapid revision of the general physiology. I recommend you to watch that after this video. Okay, because it's already done. Rapid revision of the general physiology is already done. It's somewhere around 1.5 hours. Okay, you can watch that also. Okay, so with this, all the important things for your upcoming FMGE are completed. Hope the video is going to be helpful for you. All the best, guys. See you later. Thank you.